I will. Yeah, you're good to start the meeting now, Chair.
Okay, thank you very much, Kirsty. Good morning and welcome everybody to the West Yorkshire Joint Health Overview and Scrutiny Committee, held on Zoom and live on Calderdale Council's YouTube channel. And welcome to any members of the public who are watching from home or wherever you are, but it should be at home this morning. So thank you very much for all colleagues, NHS colleagues and my local authority colleagues for being in the meeting this morning. The meeting will be, as I said, streamed live on Calderdale Council's YouTube site. If you have any question you wish to ask on the political item, if we can either use the raise hands function or use the chat function, I'd be really grateful, and then we can work through it this way. All reports are also on calderdale.gov.uk for public access, and the council welcomes the filming, recording, public broadcast and use of social media to report on the board's meeting by members of the public. So if we could, the board could introduce yourselves, and I will start with myself, and then I'll ask colleagues to introduce themselves. So I'm Helen Hayden, I'm councillor for Temple Newsome on Leeds City Council, and I chair the Leeds Health and Adults Health and Active Lifestyle Scrutiny Board, and I also chair this joint health scrutiny board. So can I invite Councillor Greenwood, please, to introduce yourself?
Yes, thanks, Chair. Yeah, I'm Councillor Van der Greenwood. I represent Windham and Rose in the Shipley constituency, and I chair Bradford's Health and Social Care Overview and Scrutiny Committee.
Thank you very much. Councillor Hargreaves.
Hi, Chair. Sorry about my lack of video. I'm Councillor Robert Hargreaves from Queensbury Ward in Bradford.
Thank you very much. Councillor Baines.
Sorry, Chair. Councillor Baines has sent his apologies today, and Councillor Bladbury is substituting on his behalf.
Oh, thank you very much. Thank you. So, sorry, who was the substitute?
It's myself, Councillor Blackburn. I'm councillor for Brighouse in Calderdale, and I'm the chair of the Adult Health and Social Care Scrutiny Committee in Calderdale itself, and I serve on the Children and Young People Scrutiny as well. So actually a nice combination. So I'm pleased to be here. Thank you very much indeed. Thank you. Thank
you for being here, and you're a busy man. Councillor Hutchinson.
Councillor Colin Hutchinson from Skirkett Ward in Calderdale.
Thank you. Councillor Smage.
Councillor Smage from Kirklees. I'm chair.
Thank you very much. And Councillor Latty.
Morning, I'm Councillor Graham Latty from the Gaisley Rawdon Ward.
Thank you very much. Councillor Clark. Do we have Councillor Clark this morning? Oh, Councillor Clark, you're on mute.
Is that, can you hear
yes,
me?
I
Sorry
can.
about that, I've problem with my technology. My name is Councillor Jim Clark from North Yorkshire. At the moment, I'm chairman of North Yorkshire County Council, but for over 10 years, I was the Scrutiny of Health chairman for North Yorkshire.
Thank you so much, and thank you for being here this morning. Councillor Soloway.
Thank you, Chairman. Councillor Andy Soloway, Skipton West Division, North Yorkshire. I'm also a trade and also very proud and humbled to be a very active part of local vaccination centre volunteers who've been wonderful. It's just been fantastic being a small
Thank you. Councillor Rhodes.
Hi, Chair. Sorry, Councillor Rhodes is having difficulty getting into the meeting, so I'll support you in the background.
Okay, thank you so much. Thank you. Hopefully we can get her in. And Councillor Whitehouse.
Not in attendance as far as I can see, Chair.
Okay, might be the same problem with the both being Wakefield. Right, lovely. Thank you very much to everyone, especially to Councillor Blackburn for stepping in there. Really appreciate it. Okay, so can I ask members if they have, members of the board, if there are any items on the agenda in which they have disclosable pecuniary or other interests which would prevent them from participating in any discussion of the items or participating in any vote upon the items or any other interests. And I can take silence as, unless somebody wants to speak up. Thank you. Item number 3, admissions of the public. Well, it's been streamed on YouTube, so I think we're okay there. Item number 4, minutes of the West Yorkshire Joint Health Overview and Scrutiny Committee held on the 24th of November 2020, and we've had a copy of the minutes. Councillor Hutchinson.
Thank you, Chair. I do have a concern. The members of the committee ask questions because they want to explore issues that have not been covered necessarily in the written documents, reports that come to this committee. The minutes from the last meeting have very detailed records of the questions that were asked, but no record of the responses given to those questions. So it really,
right.
I don't feel that they provide an accurate record of the meeting that took place. So I hope that we can get that resolved for this meeting and subsequent ones.
Thank you. That actually was my next point, because I want to say a huge thank you to Councillor Smage for chairing the November's meeting. I was not able to attend for personal reasons, and so a huge thanks to Liz for chairing that meeting. Would somebody like to comment on the lack of answers? I mean, the meeting was recorded and is available. So Mike, would you like to come in on that?
I think we can look at that and rectify that position. I think Councillor Hutchinson's making a perfectly reasonable point, and we'll make sure that the answers to questions get recorded either in the minutes or included in the papers for the next meeting, so they're on the record. We'll work that through.
Thank you. Councillor Smage, did you want to come in?
Yes, thank you. Yeah, I was disappointed when I saw the minutes yesterday and when they came out that there hadn't been more detail as to what the answers were. It was more the questions than the answers. So I'm wondering if we can say that we'll take these in parts, but then put a note with them with the answers, so that we have that record for that meeting.
Thank you very much. I believe we've got Councillor Rhodes in the meeting now. Would you like to introduce yourself, Councillor Rhodes?
Hello, good morning. Can you hear me?
I can, yes.
Okay, sorry I'm late getting in. I've had problems. I was locked out for some reason. But anyway, good morning, everybody. Hope you're all well.
Thank you. It's lovely to have you here. And I'm sorry that you had problems getting in.
But it's one of these usual things, I'm afraid, these days. But anyway, we're all together.
It is. It is.
Is there anything, Chair, from the minutes of the last meeting that you may have been discussing? I know
the lack of answers to the questions has been discussed. So we're only going to take them as in part. It's kind of like as part minutes, and then they'll be circulated round again with the answers to the minutes. So we've just been discussing that.
I'm grateful for that, Chair. And I'll make an observation, and I'm sure I've missed all of you saying the same thing probably. I constantly, and it's not just in this committee, I constantly get frustrated, I'll be kind, frustrated, at the lack of, I'll say, plain English language that answers questions rather than gives us a rethink or a rejig of paperwork that we've had before. I think it's important that questions are asked from scrutiny. I know we've mentioned this before and it's not unusual, that we do actually get the questions answered. And it's not as though, Chair and members, that there isn't enough time given for the appropriateness to be given. And I'll also say this, the respect to get the answers that we need. So I'll finish it there because obviously you've had your debate and I'm late getting into it. But on this occasion, I think it's important that we get that message out to those who we expect answers for. And it would be useful if in future that's something is very firmly understood, Chair.
Thank you. Yes, I quite agree. Okay, so we'll take those as a record in part, and then they'll need to be updated and circulated again to be taken as a true record. Okay, item number 5, public deputations. Now we do have a public deputation. I don't know whether Jenny Shepherd is in the meeting.
I don't believe she is, Councillor Hayden.
Okay, so Mike, would you like to read out the public deputation, please?
Yes, Councillor Hayden. This is a deputation from Jenny Shepherd, who says, thank you for accepting this deputation about the update on the ICS response to COVID-19, specifically test and trace, and on the ICS national policy development. So test and trace first. Councillors, during this meeting, please urge the ICS to support the call from Upper Calder Valley Contract Tracing Support to the DHSC Secretary of State, the Minister for Housing, Communities and Local Government, and the Chancellor of the Exchequer to urgently provide proper financial support for all essential workers who can't work from home, and for the small businesses that employ them when they need to self-isolate in order to avoid infecting others. As Independent Sage has explained, test and trace needs to be find, test, trace, isolate and support if it is to be an effective intervention to suppress the virus. It's unethical to test for COVID-19 if people are unable to take up isolation. Many people can't because of lack of money and overcrowded housing. This then feeds the government agenda that COVID-19 transmission is the fault of irresponsible individuals. And it says you can download the letter to the Secretary of State and others here when there's a link to that which has been circulated to members. Please also support the call in your own councils, which may well be among those who told a new local government chronicle survey they continue to be dissatisfied with central government's response to the pandemic, which scored a net minus 34% satisfaction rating. So that's the first part of the deputation, Councillor Hayden. The second part is headed ICS National Policy Development. Calderdale and Kirklees 999 call for the NHS strongly disagree with the ICS view that there is much to welcome in the proposals for the future of ICS arrangements. We too responded to the consultation, and you can find our response here. And again, the link has been circulated to members of the board. The white paper has now been published. We are particularly worried about the opaque proposal for a bespoke health services provider selection regime. With the proposed repeal of Section 75 of the 2012 Health and Social Care Act, the minimal level of accountability and transparency that derives from public tenders for contracts will vanish, and there will be no oversight from the Competition and Markets Authority. We fear this is a recipe for NHS contracting to descend into the secretive crony deals that has been such a costly disaster in the government's response to the pandemic. This already appears to be happening even without the new ICS legislation proposed in the white paper. Along with numerous other national groups, 999 Call for the NHS has just signed a letter to the Secretary of State asking him to request an investigation by the Care Quality Commission under Section 48 of the Health and Social Care Act 2008 of Centene's takeover of GP services in London. This takeover has taken place without any clarity that prior authorisation by commissioners was granted as required for two significant changes of control of a large number of APMS contracts, and with much secretiveness on the part of the 13 London CCGs that are responsible for these contracts. The changes of control have led to the purchase by a UK subsidiary of Centene Corporation in the USA of 40 plus GP surgeries across London, serving 375,000 patients. We see nothing in the white paper to suggest that such underhanded transfer of NHS services to global American corporations would not be commonplace. The letter to the Secretary of State will be downloadable from the Calderdale and Kirklees 999 website later today. That's later on the 22nd of February, and there is a link to that. And then there's a diagram of the old medico-political feudal system, England 2021, that's also been circulated to members. Thank you, Chair.
Thank you very much, Mike. Appreciate that. Okay, so following that public deputation, we are able to go on to our assessment and treatment units item 6, from the West Yorkshire and Harrogate Health and Care Partnership. So I'd like to welcome Andy Weir, Joe Butterfield, Stephen Craig, who wrote this report, and it refers to a further update members on the proposal to reconfigure the assessment and treatment units, ATUs, as referred to, provision across West Yorkshire and Harrogate Health and Care Partnership from 3 to 2 units, and to develop a single system or centre of excellence which supports people requiring ATU provision across West Yorkshire and Barnsley. In particular, provides an update regarding the further engagement work as discussed with the West Yorkshire Joint Health and Oversight Committee, Scrutiny Committee in February 2020, which now seems like a decade ago, to be quite honest, but because the world has changed on its head. Can I Mike, can I just check that the councillor from Barnsley is here? Is that Councillor Ennis?
Yes, Chair, Councillor Ennis is here, yeah.
Oh, Councillor Ennis, would you like to introduce yourself and welcome?
Yeah, Councillor Jeff Ennis, Chair of Overview Scrutiny and Barnsley Council, representing Barnsley Council. Thank you, Chair.
Thank you very much, and it's really good to have you here this morning. So, can I invite, I don't know who wants to actually start and introduce the item, and then we can go on to questions and speak to the item.
Great, I'll do that if that's okay. So thank you and good morning. I'm Andy Weir, I'm the Deputy Chief Operating Officer at OYPFT, but I'm also the SRO for this piece of work on behalf of the ICS. I was thinking exactly the same as you. It feels like an eternity away since we last came and spoke about this, and so much change. It's probably just worth doing a brief recap if that's okay. We brought to previous meetings a proposal that had taken over a year to develop, which was around the future configuration of assessment and treatment beds for people with a learning disability. This is very much driven by the National Transforming Care Programme, but also a recognition that we had more beds than we needed in West Yorkshire currently, significantly more beds than we needed, but also there was a question around sustainability of the 3 units that we were operating at the time, one in Leeds, one in Bradford and one in Wakefield. We spent a long time working with clinical staff and service users and carers to develop a set of proposals which essentially and eventually came to a conclusion that we needed 2 units rather than 3, and we went through a process using an agreed set of criteria to assess which of the 3 units would be the best to retain and what work would need to be done in those units to make them the best that they could possibly be. Really importantly, a golden thread through all of this has been that at the start of the work, we were concerned that a potential move from 3 units to 2 would be a significant concern for service users and carers. And actually one of the carer reps in the work talked at length about actually we'd far rather have really high quality specialised services than one of everything in each place. And that's become a theme through this work and it's reflected in the presentation today. We have taken the concept that she introduced into the work of the importance of developing a centre of excellence, and that's become our aspiration. We believe that with the new proposals, we can absolutely develop a centre of excellence. It's also worth saying that this is a very, very low volume service, and very few people are admitted each year. So as an indicator, in the last year in Leeds, we've admitted 3 patients into an assessment and treatment bed. So we're talking about small groups of folk. But clearly, when they do need to come into hospital, they need specialised treatment that's able to meet their needs, and particularly they need a service that's able to treat them and get them back into the community as soon as possible. So the proposal represents the national drive for reduced hospital care for people with a learning disability, integration into normal services wherever possible, and a significantly increased focus on community provision. So that's the background to the work. When we came a year ago, one of your reflections really helpfully was that we'd done quite a lot of engagement work with service users and carers, but it hadn't been highly successful. And so you asked us to go away and do some more engagement work to specifically focus on what the potential implications of these proposals might be for people who use the services, for their carers and for staff. At the time, we had a nice plan which involved lots of face-to-face engagement and open sessions, and of course that all didn't happen, and we subsequently had the inevitable pause in terms of the work. By coincidence and in parallel, during the initial COVID period, we were required in Leeds on a temporary basis to close our assessment and treatment unit due to safety and service delivery issues. And consequently, in many ways, we've moved to having 2 units that are serving the folk of 3 places. And Barnsley, of course, are also incorporated in this work because of the commissioning arrangements for assessment and treatment units in Barnsley, that the service is commissioned from South West Yorkshire Partnerships Trust. So Barnsley are very much have been involved all the way through this as an equal partner in the discussions. We have been supported by Inclusion North, an agency who works specifically with people with a learning disability. You will understand there are challenges in terms of engaging this service user population. There are ways that we've needed to do that are quite different to our usual engagement processes, but we've been really well supported both by Inclusion North and by our comms colleagues, and I feel the need to say that because actually, as you will see from the report, we've had 51 folk respond to the questionnaires and the engagement piece that we developed, and that's the best that we've ever done around this work, and I think it demonstrates the work that's gone into it and really trying to reach out to people that are not just directly affected, people who have used assessment and treatment units, but people who might do, and also other people in the community who have a stakeholder view. So we did some direct work in inpatient units still, but actually the vast majority of the work, as you can imagine, has been done remotely and has been done through a questionnaire. And a report has been produced which is attached for you and is really detailed. We've deliberately, because of the low volume and because of the granularity, we've deliberately listed almost the things that people said. We were able to do that. And so that's set out in great detail within the report. What did we find then? Essentially, really reassuringly, the feedback from service users and carers was that actually on the whole they felt either this would be a good move or that it was neutral. Some people felt it wouldn't affect them, and I think that was particularly driven by where the units are located. So unsurprisingly, the people in places where we proposed to retain units didn't feel that they would be particularly affected by the change. The main concern, there were two people that were concerned from a service user and carer perspective, and their concerns were very practical, as you would expect. They were around travel and contact, and how would we make sure that if you lived in Leeds and you were admitted to a bed in Wakefield, that your family were able to come and see you, and indeed you were conversely able to come back and spend time in the community. And we'd expected that, we'd anticipated it, and we have a really clear plan for that in terms of operating the model. So that's not a concern for us in terms of being able to make that work. The staffing and stakeholder consultation told us something different. Really unsurprisingly, the majority of folk that responded from Leeds and felt that we should retain a unit in Leeds. And we'd said at the outset that we probably thought that had we proposed that the unit in Wakefield should close, that we'd see that from the Wakefield populations, and had we proposed the unit in Bradford would close. So this is an inevitability, isn't it, about a proposal to move from a hospital base in each place to having 2 rather than 3. There were some very philosophical responses about, well, because Leeds is a big city, therefore it should have its ATU. Our response to that is really simply, we used a very, very transparent and clear selection criteria for which of the units should close. And simply, the Leeds unit currently is not co-located and does not meet the national specification for an assessment and treatment unit. And as a result of that, it requires us to significantly overstaff it and presents with some potential safety issues. So the basis for the decision for Leeds to be the place that we cease to operate is very clearly set out in the business case. More concerningly, we heard from stakeholders in the Leeds system, particularly from social care staff, that they had concerns about how the assessment and treatment units would engage with and work with community providers, and how we would make sure for the small group of folk that use those services that the community provision linked well with beds and that people didn't become disconnected by being geographically dislocated from their catchment area. And that makes sense, really. We have concluded that we have to do a piece of work specifically with the Leeds system in order to be clear about how we're going to manage that. There's nothing new about some of this, actually. We've always used some out of area placements for people with a learning disability, and certainly in mental health services we have a really long record of using out of area placements for people with mental health needs, particularly specialised placements, and where services aren't provided locally. So we know that there are things that we can do and put in place to make sure that connection is maintained, but that will require us to do some work, we think, with the system. We've been well supported by Leeds CCG and by the local authority in relation to that. So we had a meeting last week where we've agreed that actually we're going to have a system meeting, a virtual system meeting, to talk with some of these stakeholders about, so how can we tackle this problem? What exactly can we do? And is it a real problem or is it an anticipated problem? Staff understood the proposal better, and not least because they've been involved in it. And really reassuringly, people felt that the model would deliver the improvements that we want it to deliver, that it was the right direction of travel generally to have 2 units rather than 3, albeit that there was still some debate about which unit, and parochially, as you would expect, staff from Leeds generally said they thought it shouldn't be the Leeds unit that closes. But people really felt that if this was consistent with national direction, would bring better coordination of care and actually would allow us to provide better quality care, and at the end of the day that was the intent of the work. People also reflected the practical concerns about travel, how would carers be involved, the stuff that you'd expect, really. And so those are the things that, as I say, we'd thought about that. We particularly thought about that around the equality impact assessment, and so we have a plan for that in terms of the operational plan that would get us to where we need to be. And then finally, really reassuringly, a whole number of staff offered suggestions about how the work could improve, how we could make sure this works moving forward. And a number of people very clearly said, we want to be involved. We want to be more involved in the granular detail of the operational plan and the transition into the new model. And that's great. And it's our intent to actually engage those staff and use them moving forward to make sure that the real detail of the proposal works. So having reviewed all of that, our conclusion was that actually there are some concerns, particularly from stakeholders in Leeds, about what this will mean for Leeds residents in terms of a disconnect between their community health and social care provision and inpatient beds. But we've got really clear evidence in other services that we can make that work, that actually we can't sustain the 3 units. There's no doubt at all that we could carry on as we are at the moment. And in fact, the fact that the Leeds unit is temporarily closed just demonstrates that, frankly. So this is absolutely, we believe, still the right direction of travel. We believe that still the intent to deliver a centre of excellence is the right one, and we think this will provide the opportunity to do so. It's been superb that the CCGs have maintained the level of funding. I think, I have to say that actually the intent is to maintain the same amount of money that's spent on 3 units, but spend it on the 2 in order to make sure that the 2 is able to deliver the centre of excellence. So this isn't about cost reduction or saving, it's actually about doing something better and meeting need better in a more consistent and sustained way. So we have concluded we need to, and have started to draft a "you said we did" document. So following the consultation process and the engagement, we now want to say to people, this is what we've heard, this is what we've done about it, and make sure that people understand the closure of that loop and have opportunity to still be engaged. But we believe that we are now in a position where we are able to move forward and implement our proposed new model. Because there's nothing within the engagement that surprises us particularly, or indeed seems to prevent us from moving forward with the proposal as it was made. I don't know whether any of my colleagues wish to add.
Yeah, I'm just going to ask if anybody else would wish to add to that. Thank you very much, Andy. That was very detailed. I have got questions, but if anybody else wants to. Karen Coleman, would you like to come in? Good morning.
Sorry, morning everybody, nice to see everybody. I think the only thing I'd like to add really on top of what Andy said is that a really important part of any engagement work we do is feeding back. So we will be putting robust processes in place. It will be doing the you said we did, but we'll also be writing to everybody in easy read and making sure that all the staff that we engage and who reach the people who access the units, they get their feedback in the way that is comfortable to how they would want to receive that.
Excellent, thank you. Okay, so I'll go to questions from members of the board. So I'll start with Councillor Hutchinson and then Councillor Smage. Councillor Hutchinson.
Thank you, Chair. I'm really pleased that it's been recognised that ATUs are only a part of the care for the people who are making use of them, that they're just a stage, and the interaction with the community services is really important. So that it's vital that this work is done to make sure that the community services are actually embedded within the ATUs to make that transition into and out of the ATUs function properly. So good luck with that work. The information that was provided suggested that there'd been a major change in the number of people making use of the ATUs since the last report back in February 2020. And I should imagine that part of that is a reflection of, I should imagine that there's been a change in the threshold to admission to these units with the recognition that the death rate from COVID has been 3 times higher amongst people with learning disabilities than it has amongst the general population. So maybe going into a unit like this, there may be higher thresholds, but we were told that there had been no out of area placements for more than 18 months last year. I would like us to know whether that has been maintained or whether there have been out of area placements required over the past year. I would also point out that on page 20 of the report, where the views of service users and carers were sorted, the answers, there were only 9 people out of the 8 people out of the 17 respondents actually answered that question. And if you look at the responses, it suggests that they didn't actually understand what the question meant, because when it's saying, how can you tell us why the changes are good, not good, or will not affect you? So one response was, I don't know. Next one was, it means I can go home. The third one was, it means I can go out for a walk. Fourth one means, it means I won't hit people. It doesn't suggest that they're giving, that the answers actually can be used to say, well, the majority of people said it wouldn't affect them, or that it's better. They don't actually. So I think that question should be discounted from the analysis. As with so many of these reorganisations, one of the key drivers has been lack of trained staff to actually staff 3 units in this case. And the responses from staff members really flag up the problems with staff shortages and high number of agency staff being required to man these 3 units. I have difficulty in looking at the proposals to see whether we can be assured that a reduction to 2 units will resolve these issues in the long term, and what the grounds for your belief that it would be. So I would particularly like to an answer to that question. Thank you.
Thank you. Would it be you, Andy?
Yeah, so In answer to the out of area placement question, we have placed one person out of area who required an ATU bed, but in actual fact, he required an ATU. We couldn't safely care for him in either of our 2 units. We had beds, but he has specialised needs. And the conclusion of both of the units having assessed him was that he needed to go to an alternative unit out of area. So that wasn't about bed availability, that was about his individualised need and was particularly appropriate at the time. But other than that, we've maintained a low occupancy, and of course you're right. You know, the last thing we want to do is be bringing people into hospital where we don't need to at this point in time, although clearly some folk do still need to be admitted. I think that the reduced occupancy also is reflective of the investment in community services and the new community models that have developed over the last 2 years. I think we're starting to see the benefit of those, and particularly of some of the arrangements that are in local places around respite provision. And you may remember from the first presentation that one of the really high rate of reasons for admission into our assessment and treatment units isn't actually identified health need at all, it's placement breakdown, and that people are being brought into hospital because their current placement had broken down and there was nowhere else for them to go. And sometimes that even resulted in detention under the Mental Health Act. And clearly that's not at all what we aspire to. And I think as systems have started to develop alternatives, that's reduced, thankfully, because that was a really significant issue, both in terms of rate of admission and length of stay. In terms of the staffing issues, you're absolutely right. Are we entirely confident it will remove all of those issues? No. There's a real national shortage of nurses. There's particularly an issue around the pipeline for learning disabilities nurses and people with those specific skills. We have revised the skill mix to make it more achievable, we believe. So the profiles of the staffing that we'd be expecting to use in the 2 units are different to the profiles of the staffing we were trying to use in the 3, but there will no doubt continue to be some challenges in terms of provision of learning disabilities nursing, particularly. That of course isn't helped by the fact that some of the Leeds nursing staff won't move, we anticipate, to the unit. So we have to be realistic about that as well. We've never assumed a migration of staff from one place to another. But we're doing a lot of detailed work at the moment, looking at what does the staffing profile look like in terms of setting up the 2 new units. And in real terms, we're using those staffing numbers now anyway in the 2 units that are operating. So I think there's a more strategic piece that we need to do around learning disability nursing and thinking about how we get people with those skills into training, actually. I'm hoping I've answered the questions that you've raised, but I'm sure you'll tell me if I haven't.
No, that's really good, and I would hope that you can make progress with the encouraging people to train up as learning disability nurses. I mean, that's essential. Otherwise, we'll be back here looking at reduction to 1 unit before long.
Absolutely. Councillor Smage and then Councillor Latty. Councillor Smage, please.
Thank you. On the paper that you've provided, you say that you want people with learning disabilities to be supported in mainstream hospital wards wherever possible, with services making reasonable adjustments to the usual practice and meet their needs. How is that being achieved, please?
Okay, so there's a national policy called Green Light, which requires us to and ensure that mainstream services are able to be accessed by people with a learning disability. And how that's worked in practice is variable. So we currently have seen a significant increase in the number of people with a learning disability that have been admitted to acute adult mental health wards, for example. Where you have a staff team with a skill mix that incorporates some learning disabilities experience, or people have access to learning disabilities expertise, then that can work really well. But sometimes it doesn't. And that's often the deciding factor in whether or not someone needs to come into an assessment and treatment unit, actually, about whether or not the acute admission ward is able to meet their needs. There are also real issues around acute admission wards tend to be busy places with lots of activity, lots of noise, and sometimes they're the worst place you want to put someone with a learning disability, particularly if they have an autism as well. And so clinically, that's a decision that always needs to be made. I think we absolutely have to aspire to making sure that all of our services are accessible. So I can talk about, here in Leeds, we have a small team of learning disabilities staff who specifically do this. Their whole job is to help people in the community with a learning disability access mainstream health services, be it dentistry, be it primary care, etc., etc. And certainly across the acute trusts within the ICS, there's some really good examples of people having learning disabilities expertise that help people with a learning disability to have a far better experience when they need to go into hospital. So I think, does it always work? No. There'll always be a need for some people with a learning disability to access specialised services, but can it work, and is it something that we should actively be working on and pursuing? Absolutely, I think it is, because I think it's the right direction.
Okay, thank you.
you.
It's just that I was concerned that if you're reducing the capacity in the ATUs and you haven't got hospital provision right, then there may be an issue there. But also about the community support, you mentioned about people remaining in hospital because a suitable care provider accommodation can't be found, and that you'll increase community support. And I'm just wondering how that has progressed over this year to help you in reducing the number of ATUs to 2.
So community support continues as before, and as with all services, we've had to adapt the way that we deliver community support. But in our community learning disabilities teams, for example, we still have face-to-face work, we're still doing direct contact with people, we're still seeing them at home, albeit on a lesser basis than previously. And that's very much based upon assessment and risk assessment and assessment of the service users' needs. The work that's gone on around under the Transforming Care programme around developing community infrastructure, things like intensive support teams, has been superb and has made a real difference. And I think, certainly across the ICS, we can demonstrate that that's significantly contributed to the reduced need for beds. We are significantly underoccupied even within 2 units currently. And that's not just about COVID adjustment, that's about having better alternatives to people in the community, particularly those that prevent admission. So the fact that we have people on risk registers who may be at risk of admission and we're able to take proactive action to reduce that when we know that that's likely to occur, that's a real change. That's occurred in the last few years, and it's made a real difference to the flow in and out of units. The most significant challenge, albeit that it has changed a lot in the last 2 years with the Transforming Care programme, is access to appropriate accommodation. So the thing that is most likely still to cause someone to come into hospital and stay there for a very long time is that there isn't anywhere for them to go when they leave that's best able to meet their needs. And that's an ongoing piece of work that's being done across our CCGs and our local authorities around market engagement, understanding what need is, etc. But actually, without a doubt, community change has happened at pace in the last 2 to 3 years and is having a very significant impact on hospital bed use.
Thank you. Councillor Snowden, would you like to come back?
Okay, thank you.
Lovely. Councillor Latty, please.
Thank you, Madam Chairman. I suppose to some extent this has been touched upon, but during the period under review, you were saying that Leeds has effectively been closed. Has there been, during that period, was there any need for the service? If there was it coped with within the other 2 units or the specialist team that you referred to in Leeds? Did they cope with it? And going forward, is that specialist provision something that indicates that perhaps Leeds could be the one to face the closure?
Okay, so we're really clear in our proposal that the Leeds unit is the unit that will close. So that's a decision that we made well over a year ago now through an engagement process and a process that I set out earlier through a set of criteria. We have admitted, since the Leeds unit has been temporarily closed, we've admitted 2 patients from Leeds into assessment and treatment beds, and they have been admitted into the other 2 units, one into Bradford and one into Wakefield, into Swift. And actually today we have lots of capacity within our assessment and treatment beds. So we can absolutely demonstrate that the demand is met by having 2 units rather than 3. The community provision is the intensive support provision is being developed in all of our places. It's part of the Transforming Care programme, but I'm really confident that it will continue to develop in Leeds. So our conversations with our local commissioners has been actually there's a need to think about investing more in that community infrastructure. Regardless of the ATU beds or not, it's the right thing to do, and we need to keep people out of hospital and get them in hospital for the shortest possible time.
Councillor Latty, would you like to come back? Or? Thank you. Councillor Ennis, please.
Yeah, thank you, Chair. I mean, we're delighted that the Wakefield unit is going to be retained, primarily because of the close proximity to it from Wakefield to Barnsley. So that's a really good positive. Our concern is about the future funding costs, because currently at Horizon we block purchase one bed there, and under the new proposals, although the financial details are fairly sketchy, we're going over to a daily bed rate system where you pay for the usage of the beds at the two particular units. But because the financial costings are sketchy, we're just a bit concerned that under the new model, is there likely to be any big increase in the charges to commissioners for the revised service? That's the nature of my question, Chair.
Okay, so the new model isn't based on an actual cost model. The proposal has been that for the first year, the commissioners will invest a baseline which is equivalent to the year of the investment for last year and this year. So actually, the expectation is no one will pay anything more or less than they're currently paying. Then there's a piece of work that we're concluding currently across the CCGs in terms of how we manage the level of investment across the 16 beds from year 2 onwards. So clearly some CCGs, as you described, would say, well, we've historically only ever invested in one bed, we might only use one bed, and actually we only want to pay for one bed. We're trying to work through a mechanism of how do you manage a collective 16-bed enterprise across 6 CCGs and make sure that no one feels that they're disproportionately paying for something that they're not getting, whilst also recognising that, you know, potentially you won't pay for entirely what you get, because that's not how it works when you've got a collective commissioning arrangement. So there isn't an expectation that there will be any increase in expenditure.
Thank you, Chair. I'm happy with Andy's response to my question. Thank you.
Thank you very much. I'm not seeing any other hands up. Andy, the really detailed answers. Thank you very much. Comprehensive, as is the report, and the fact that you're going to write, as Karen says, to everybody who like responded. Sorry, I've got a 9-year-old who's stressing about his maths. If anyone could help him. That'd be great. Yes, so we've I'd also like to echo what Councillor Hutchinson said about you know, that kind of community work and recognition that people kind of want to be in the community and supported by the community, and the fact that you're having meetings with, you know, other stakeholders and seeing it as a whole system thing, I think is really, really positive, because we don't want people in units any more than they have to be. We want them in the community and with their family and friends, and as much as anybody can be at the moment. So thank you very much. Oh, Councillor Greenwood, do you want to come in?
Sorry, Chair. Yeah, just a really quick one, actually, because obviously as one of the areas, Bradford, where we've got one of the units. I mean, as we've gone along, a lot of my questions have been answered. I was going to ask about the easy read, but Karen's answered that anyway, and she's confirmed that communication is going out. Before I ask the question, which I think has probably been answered anyway, I just want to say to everybody, thank you for this, because I think it's been a really, really good piece of work. I think people have communicated really well with us, with the community, with the service users, and you know, the outcome has been really welcome. So thank you for that. What I was going to ask, Andy, and I think you've probably answered this anyway. I know it's a very low volume service, and we've only got so many beds, but what happens if all of a sudden we get more people that need the service than beds? Have we got any sort of contingency for that?
So we would initially do as we would always do if we had an increase in demand. We would need to look for alternative provision. So, you know, if that happened and we really did need to identify. So today, if it happened today, we would identify an independent sector or another NHS provider who was able to sell us beds, essentially. I'm really, really confident, unless there's a sudden surge, that we wouldn't get there at any volume. But if we did, that's what we would have to do. If that was then sustained, clearly we would need to rethink, and we'd need to think about, actually, you know, is there an alternative bed base? Do we need to purchase something on block, etc.? But hopefully that's not where we'll get to. The other thing is that we've always got at any given time a couple of people who are delayed in the beds. So actually, you know, routinely when you need beds and you haven't got them, one of the first things that you do is look to see, is there anything that we can do with those folk who don't need to be in hospital anymore to accelerate their move out of hospital. But again, you know, you need to be careful about that in terms of risk and planning.
That's great. Thank you.
Thank you very much. Right, yeah, lovely. Have I got any more questions on this item? If colleagues wouldn't mind putting their hands down. I feel like I'm back teaching. I didn't teach maths, as you can probably be aware, but that would be great. Okay, thank you so much, Andy, for your responses this morning, for all the work that you're doing for some of our most vulnerable yes, residents, and if we and I suppose in some future point, if you could give us a quick update on how it's actually been implemented and how it's all gone and things like that, we'd be really grateful. So thank you very much.
Thank you. Thank you for your time.
Thank you. Okay, thank you very much. So we will go on to item 7, which is the West Yorkshire vaccination programme. And thank you to Dr. Phil Wood and Matthew Graham for the report. So this item will consider an update from the West Yorkshire and Harrogate Health and Care Partnership on the rollout of the COVID-19 vaccination programme, which I'm reading from the letters that have been sent through, and just from, I don't know what everybody else is feeling like, but the personal experience in Leeds, that it's really excellent and going really, really well. And before I bring Matthew or Phil to speak on this, I'd just like to thank everybody, including our volunteers, as Councillor Soloway was talking about, people who dug out surgeries in the snow, the council colleagues who grit the road so people could get to their vaccination policy. It's a whole team effort, and I'd just like to say a huge thank you to everybody across all local authorities, across the NHS and CCGs, everybody involved, our volunteers, third sector, the Red Cross for driving people to their appointments who couldn't get there. So and all our West Yorkshire colleagues who facilitate, who find those barriers, who make sure that those barriers are taken down. And so I'm really, really excited actually to hear about it. So I don't know who wants to speak to this item before I take questions.
Thank you, Chair. Good morning, everybody. My name is Matt Graham. I'm my normal job, my day job is as the director of the West Yorkshire Association of Acute Trusts. But just at the moment, I've been the programme director for the West Yorkshire Vaccine Programme. Phil Wood, who's the medical director, the chief medical officer at Leeds Teaching Hospitals, and the senior responsible officer for the programme, is actually on leave this week. So I'm deputising for him today. So thank you very much for your very kind words, Councillor Hayden. It has been a real honour, a real experience, a real bit of a roller coaster to be part of this programme. But it has been, as you said, a real whole system approach to this that has been brought in people from the NHS, people from the local authorities, from the wider voluntary sector and public sector to really make this programme work. And I think it's really important to recognise that. We've had colleagues from the fire service and a whole range of other organisations working with us to deliver this programme. It's really important, I think, to say that it's very much been a place-based approach. We've not tried to run this at West Yorkshire level as a whole. There's been a lot of coordination at West Yorkshire level, but very much running it at place level so that we're making the best of the local knowledge and the local links and community engagement that we've got in each of our places. But just to update the headline figure that we had in the paper, obviously the paper was written a couple of weeks ago. So as of Sunday, the 21st of February, we have now delivered over 650,000 vaccinations to people in West Yorkshire. And we did meet the national target of offering a vaccination to everyone in the first 4 priority groups. So that's effectively everybody over the age of 70, anybody who is identified as clinically extremely vulnerable, and frontline health and social care workers. And we offered the vaccination to all of those people by the 15th of February, as we were asked to do. So just to pick out a few things from the paper, I think it's important to recognise that we are following the JCVI guidance, and as I said, so we have offered a vaccination to everybody in the first 4 cohorts, and we're now focusing on cohorts 5 and 6, so that's 65 to 69-year-olds and those people with underlying health conditions which put them at risk from COVID, and their carers. And we'll be moving on to other cohorts as we work our way through those groups. Vaccinating through a wide range of sites. Excuse me, if you can hear the printer sat next to me, it's because my children are printing out their schoolwork at the moment, so apologies for that sound. So we're vaccinating through a wide range of sites. We've got hospital sites, over 40 primary care sites spread across the whole of West Yorkshire, community pharmacy sites, and some sort of dedicated vaccination centres. I think it's also important, we've also got identified that in some areas we need additional sites to help us access and improve the uptake from particular groups and particular communities. And for those areas we've provided additional sort of pop-up sites, for instance in local mosques in Bradford, and in other parts of of West Yorkshire, to try and help ensure that we really are getting out and reaching those communities where, for whatever reason, the uptake isn't as high as we would like it to be. Just as the latest, to give you a sense of the latest figures, we have now vaccinated over 90% of everybody over the age of 70, and we've already vaccinated over 75% of people aged 65 to 69. And that's we've only been focusing on vaccinating those people for a couple of weeks now, so that's quite a good, I think that's an impressive state to be at this stage. I've talked a little bit about encouraging uptake, but I think it's worth emphasising how conscious we are of this. And Ellen Nossiter, who is our communications and engagement lead, is also with us today, and she's been leading a huge amount of work with local places, and importantly at a more sort of local level than that, in neighbourhoods and in specific communities, to engage with local people, to engage with trusted voices in those communities, faith leaders, community volunteers, and people like that who understand their local communities, to encourage as high an uptake as we can get in those areas. The next steps, as I said, we're focusing on the age group, the 65 to 69-year-old age group at the moment, and those people with underlying conditions and their carers. We're also continuing to follow up with people from the older age groups who haven't come forward for vaccination, and try to encourage them to come forward and get vaccinated. It's really important to say that this isn't a sort of a one-time offer, and if you don't miss your slot, you can come forward at any time to get vaccinated if you've not come forward, and we'd be very happy to vaccinate anybody who comes forward from groups that we've already been focusing on. The other part is that we'll be starting second doses for people who've already been vaccinated over the next few weeks. At a small numbers, those will be starting this week, and that will ramp up over the next few weeks as we get into as we get into larger numbers into the beginning of March. So if that's okay, Chair, I'll stop there. I think there's most of what we needed to say was in the paper, but I'm very happy to answer any questions that the committee has on the programme. So thank you very much.
Thank you very much. I don't know whether Eleanor, you wanted to say anything to add to that?
I don't think so. Only just how important, stress what Matt has said about how important the work with the local communities is and the uptake and the communication side of it. But again, very happy. I know that's something that members will be interested in too. So happy to answer any questions.
Thank you both. I do have 5 questions at the moment, or 6 now. So I've tried to write them down in the order that the hands went up. So I'll start with Councillor Clark, then Smage, Hutchinson, Latty, Greenwood and Soloway. Councillor Clark, please.
Yes, thank you very much, Chairman. I would just like to endorse the comments you made, because I'm a bit of an outsider, because I had my vaccination in Humber, Coast and Vale, and that's something I'll be coming on to in the next item, that West Yorkshire, in relation to the vaccine, Harrogate is not in West Yorkshire for the vaccine programme. But I think the important thing is that it's been an enormous success, and this was the NHS at its best. And I was able to go along. It was 3 weeks today, so I've probably got good immunity now, but I was able to pay tribute to the volunteers and to the members of the NHS, and they actually took a photograph of me being vaccinated. It didn't get as much publicity as I had hoped, because it was done on the same day as there was publicity for the former Archbishop of York, John Sentamu, and the Lord Mayor of Leeds. So, but I wanted to get across, and I've been doing this all the time, and I encourage other members of this committee to tell people to take up the offer of a vaccination. It's very important. There are some people who still have doubts, and I say to everybody that I meet, and some people are still concerned, but as I said at the time, I've had vaccinations from the NHS for the whole of my life. I'm one of these people who's older than the NHS. I was born in 1947 and the NHS was founded in 1948. And I tell people that the interesting statistic with the vaccination programme, and I pay tribute to all those involved in it, is that most of the people at the start, and it will change now, but most of the people who were vaccinated in the first few months were all older than the NHS itself. If you were over 73, then you were older than the NHS. And I think it just shows the tremendous impact the NHS has had on this country. And I pay tribute to everybody, and also the volunteers. And Andy mentioned earlier that he's been volunteering, but I'd just like to say, as somebody who wasn't in the West Yorkshire programme, but in the Harrogate programme, it has gone tremendously successfully. And I think that's the one major part of this whole nasty business we've had over the past year, that it brings us great hope. So congratulations to you all. And I ask all members to go out and tell people to, once they get the letter or the phone call, to take up the vaccination, because that's how we will manage to make the whole world a much safer place. Thank you very much.
Thank you, Councillor Clark. Yeah, as somebody whose father is the same age as the NHS, but spent the first 10 years of his life without the NHS in Ireland, and he can remember, having to pay for doctors and things like that. So it is an extraordinary, the whole NHS is an extraordinary achievement, but it is at its best. And And yeah, I completely echo. I don't know whether, Eleanor, you want to say anything about vaccine reluctance that Councillor Clark talked about there, and what kind of is happening around that. But I'd just like to say that somebody said to me, because I've had quite a few of people who are older than the NHS phoning me who have got their vaccinations and delighted. And one of them said to me, but we remember a time when there wasn't vaccinations, you know, so when people did get polio and things like that. So maybe actually our older population are much more less reluctant, but now going to the younger generation, whether there's more reluctance there.
So yes, in terms of hesitancy, there are obviously some communities where we know there's likely to be greater hesitancy and that we are seeing it. I think we've talked a bit about in the paper about BAME communities, but I think it's important to say that's not a wholesale. You know, we're referring to some people within those communities and particular concerns that have been addressed as we know more about the vaccine. So, for example, what's in it in terms of animal products and whether it meets with people's religious beliefs. So what we're trying to do very much is make sure we've got accurate information out there. There is a whole wealth of misinformation, and there's also a lot of anti-vaccination misinformation deliberately put out there. I think we recognise we're not going to persuade people who are completely anti-vaccination, but what we want to do is make sure that people who might have some concerns have the chance to get accurate information on those and have the opportunity to discuss them as well. And that's a big part of what we're doing with the community work. So working with voluntary sector and local authority colleagues to have conversations within those local communities. So we've made sure they've got briefings, materials that they can use, sources. Again, not all, I mean, obviously the NHS, we hope people would recognise as a trusted source, but endorsements and information from people from those communities themselves. So there's a big initiative going on and building on that, and which we'll link into the funding that has been given to councils to expand the COVID and vaccine champions. But it's starting off, so it's really, as Matt alluded to, it's the trusted voices approach. It's recognising that people want to see people like them getting the vaccine, hear from people like them, hear from either GPs, faith leaders, other people in their communities that they do have that relationship with. So a lot of our work has been making sure that the information is out there and is going out through those channels. We are trying to back that up with doing specific events. You'll have seen around all areas, Facebook Live events, and where there's a particular concern coming out in a group, something perhaps to address that. So one you may have heard of is around fertility. There's been a lot of concern about whether the vaccines will affect women. It seems to be predominantly concerned about it, younger women. And although obviously that's not been the primary age cohorts we're looking at, that has been applicable in health and care workers and, for example, staff in care homes. So we've done a lot of actual targeted work with those groups, including things like GPs going into the care homes to have the discussion with them, or some specific groups, discussions online with fertility experts. So we're trying very much to take a targeted approach, and also recognising that if we go out wholesale and repeat the myths, actually we raise anxiety. The way of addressing them is to have the conversations with people. So it's a much more time intensive process, but the right thing to do. And I think we all sort of understand as well that some of the hesitancies in communities where they feel a bit done to and don't want to be sort of told they have to have the vaccine. They want to feel able to make that decision for themselves. So part of the approach we're taking is to try and empower people to find the right information and feel they can take control of making that decision as well, rather than sort of trying to bludgeon them into it. So we're happy to take any more questions on that, and I'm expecting one probably from Councillor Rhodes, who I used to work with in my Wakefield day, and it's very nice to see again her and Andy.
Lovely, thank you. So I'll go on to Councillor Smage then, please.
Thank you. It is an absolutely tremendous effort that is happening to vaccinate everybody, and I join Councillor Clark with his comments about trying to encourage everybody to take up the vaccine. It is really important. But I want to ask about carers and how carers can access the vaccine, because under the 5 and 6 category, carers are able to get vaccine out there. And there's two parts to the definition that's being used. The second part is a main care of an elderly or disabled person whose welfare may be at risk if the carer falls ill. And I wonder how you're applying that in West Yorkshire, because many people won't think of themselves as carers as such, and they might not know where to let somebody know that they are a carer. So how are you applying that across West Yorkshire, and how are you putting information out to people to help them? Thank you.
Matt, do you want me to pick up, or do you want to do the beginning and after with the comms part?
Shall I start? And then so I think we're lucky in West Yorkshire that we have a really strong carers network across all parts of West Yorkshire, and a really active carers network. And they've come up with an approach to help us to identify people who, firstly, people we know of as carers, and ensure we're inviting them in through primary care sites predominantly to be vaccinated. But also, as you say, to start to again work with the voluntary sector, and as Eleanor will describe, I'm sure, communicate out to say that these, if you're in this sort of situation, that you are eligible for a vaccination. And I think, as you say, Councillor Smage, it's important to recognise that not everybody will see themselves as a carer. Not everybody will want to be seen as a carer. So we had some sort of feedback from somebody who said, I suppose I am a carer given the definition, but actually I don't see myself as a carer. I see myself as a wife, a husband, a partner, a mother, a father, and in some ways don't want to be badged as a carer, but actually they are eligible to be vaccinated within that definition of what a carer is. So we're trying to be sensitive to those feelings as well, while encouraging people to come forward. And obviously it's GPs know of people who are in those sorts of situations through the contacts that they have with their population and the population that they serve. So that's one of the reasons why GPs are sort of the primary route to vaccinate carers, because they can have those direct conversations with people that they know it would be relevant to and are eligible. Ellen, do you want to add anything to that?
Yeah, I'll just add a little bit, just because you were away last week, Matt, when some moved on. It's those hidden carers, as you say, Councillor Smage, that are the real sort of concern, because if you are registered with your GP or receiving carers allowance, you will automatically get invited from the national booking system as well, as your GP. It's just sort of whoever gets first, so they're picked up. What we're doing is each place has made arrangements with one of their local carers organisations, so we've got arrangements in place. They do vary, which makes it harder if we're talking about a West Yorkshire approach. But so at one end, we've got it where that carers organisation is collecting details of anyone who thinks they may be eligible. I'm ever so sorry. Sorry, I've got somebody waving at me because they're scared of my dog trying to deliver something. And they will actually triage them, make sure they are eligible, and then pass all the information on to their local practices. And then we've got other arrangements. So in Calderdale, where there's actually a dedicated booking system for carers, so that people who aren't registered yet can go on through that route. And then we've got sort of a mixture of in between across the places. But supporting that is getting the information out. So, and again, the language we're using, we're being very careful, guided by our partnership colleagues around. So it's not, are you a carer? It's very much about, do you look after a loved one who needs your help, or who, without your help, would need more intervention or something like that. So we've got a variety of approaches, but very much linking with where local authority partners, carer organisations, and then key to this is also our GP practices, because at the start they were under the impression, I think, that it would only be people who are either registered with them or have a carer's allowance. So we're just going through the process of making sure that every practice understands who is eligible. We provided a consistent definition of what that means for us as West Yorkshire, so that it's, for example, we're talking about somebody who provides regular care, minimum of weekly, and who either lives with or who's in the support bubble for the person they are looking after. So it's a fairly wide definition, and I think we're also recognising that if possible, it would be helpful for people to be registered as carers, because there's other benefits to them, you know, and the support that they will need from being registered as a carer with their GP practice. So we're hoping there'll be additional benefits from that. But we're just about to start, once we've got all the arrangements completely lined up with who rings who and where you go, we're just about to start some publicity through media, and again, using people who've had a vaccination who will be saying things like, I didn't think of myself as a carer, but, and very much trying to do that to bring it alive to people and get people to come forward.
Okay, thanks. Can I just clarify, when you say about regular care,
yes,
are you talking about personal care, or are you talking about a wider definition of care?
It didn't have personal care. I'm sorry, I haven't got the document in front of me. It says weekly, it's basic, without which it qualifies it, but without which the person would need an intervention from NHS or social care on it. So we haven't specified what it is, recognising there's a wide variety. Yeah,
that's fine. Thank you very much. It's just that there is such a wide definition of care, and I'm just concerned that people do come forward, and there is those communications out there to help people do that, so that, you know, people are supported in it.
Yeah.
Thank you. And an excellent question. Thank you, Councillor Smage. Councillor Hutchinson.
Thank you, Chair. I'd like to echo the words of Councillor Clark and Councillor Smage in how impressed we are with the way that the vaccine rollout has gone, and the way that it indicates how powerful the public service ethos that's summed up by the NHS is, and how the amount of support that there is in the wider community for that public service ethos. I've been leading the COVID Champions project in Calderdale since August, and a major part of that is hearing from people out in the community as to what we're doing that's working and what we're doing that isn't working, and try and see whether we can flex the public health response as a result of that. One of the concerns that we know how important trust and confidence is in the vaccination programme, and part of that is people feeling that it's completely transparent, that the information that they're giving meets their needs. And one of the concerns that's been raised by quite a number of champions is that there seems to be we know that the vaccines that are available, more than 10% of people will get some adverse reaction to this, and that for the majority of them it's going to be mild, aching at the injection site, muscle aches, headaches, maybe a period of fever, and that can, for a few people, that can be quite significant for a number of days. Now, there seems to be a difference in the information that's being presented to people before they actually have their inoculation at the mass vaccination centres like the John Smith Stadium, or at the community pharmacies where this is being delivered, or at the hospital trusts, compared to the information that's being provided at primary care settings, certainly within Calderdale. And I'm really asking whether this is something that is purely a Calderdale experience, or whether it's more widely across West Yorkshire. From my own experience, it backed it up. Last week I was called to a primary care setting to have my vaccination by text. No mention of any potential adverse effects from the vaccination, either through the text or before I actually had the injection given. And as I say, this backs up the information that we've been getting from other champions within the scheme. And I just wondered whether this was a purely local thing, or whether it is more widespread, that are people actually having because as we move to younger people who have to go to work or have other important commitments that they need to keep, if a number of them are experiencing not being able to go to work for a number of days because of the impact of the vaccine, the people who will be most upset about that and most likely to relate their experiences will be those who feel that they weren't informed before that there was a chance that this might happen. And I would like us to try and make sure that that doesn't happen, because it is so important that we get as much coverage of the vaccine as possible. So I'd just like to know whether this is a local issue that we need to address locally, or whether it is more widespread. But it does seem to be related to primary care settings, not to the mass vaccination centres or the hospital-based centres.
Okay, so thank you, Councillor Hutchinson. That all of the sites get the same information and have the same, are expected to give the same information to patients, people when they come forward to be vaccinated. So there shouldn't be any difference. That's not something that certainly I'd heard of as being an issue previously. So we will pick that up with all of our place teams to ensure that everybody is being given the same information across all of the sites. As I say, it should be the same. So we'll just need to check what's happening there. Eleanor?
Yeah, you won't get anything beforehand if you're invited by text, but you should get a leaflet of what to expect after having your vaccination when you're there. Yeah, so that's what Matt's talking about, that we'll follow up, and that is the same information that is. And we certainly, on all our information on the website, this is throughout the NHS, it does highlight that there is potential for side effects and what those are. So it's not something we're trying not to highlight, and it's certainly something in our conversations that we're picking up to explain to people that you may feel a bit unwell. So it's not, it's something we're trying to be very open about. And it sounds like, as Matt says, what I would say about the GP practices is they don't always get their much notice of when they're getting their deliveries, and so there can be a lag. So sometimes it could be that they've run out of the leaflets, but we need to obviously try and find a way of making sure they have the information to give out. So we'll look at that.
But the consenting process should be exactly the same in every setting, and therefore the conversation you should have with the person who is taking your history and doing the consent process should be the same and should cover that. So even if the leaflet wasn't available, you should have been told that verbally, and we'll make sure that's we'll pick that up.
Chair, may I just come back? I honestly, really do not think it's appropriate to tell people after they've had the injection that they may get adverse reactions. They need that information before they have it.
I think the point is, if you get notified by text or a phone call, there isn't the opportunity to by written form to give that kind of information. But as Matthew said, when you go for they have to do a consent process, don't they?
No, not in my experience.
Oh,
so James, we've got James Thomas, who's one of our GP leads, who's on the call, and I think would like to make a point here.
Hi, James. Thank you.
Hi, Alan. So just to respond, I would expect, as a GP who gives them, I would echo in terms of what Eleanor has said, in terms of sometimes we don't always have the leaflets there, but I would expect during the consenting process and prior to actually giving the injection that we explain the possible side effects so that they are aware of that there. And then we will give them a leaflet as well, so they can have more time to reflect on that afterwards. But we do speak, and I would expect that to have spoken about the side effects prior to actually giving the injection in a PCN.
I wonder if that's something that colleagues can pick up at a more local level. I certainly haven't heard in Leeds of any anybody that particular concern. So it might, as Councillor Hutchinson said, it might be a Calderdale thing. So if we could pick that up,
we'll mention it to all of the places and highlight the particular concern that Councillor Hutchinson's raised, and ask them all to check that is happening and the right information is being given.
Thank you.
Thank you.
Okay, so I've got Councillor Latte, Greenwood, Soloway and Rhodes. So Councillor Latte, please.
Thank you, Madam Chairman. Right, we're getting now into the second phase where people are going to be having their second vaccinations, their second jab. I'm just interested to know, this is really going to sort of double the numbers of people going through the various places where vaccination is taking place. And it's also going to double the number of doses needed. Are we happy that we've got, one, the capacity to cope with this smoothly, and that we've got the vaccine to do it? And just a question out of interest, do we get the same vaccine the second time? And does it matter? Thank you.
So
good question.
So to take the last bit of the question first, because it's probably the easiest piece. You do need to have the same vaccine as you had the first time, and through the clinical systems that we're using to record the vaccine being given, we'll know which vaccine you were given the first time round, and we're tracking that, and we're making sure that the sites are then given the right amount of each type of vaccine at the right time to be able to call people back at the right point to give them the same vaccine for the second dose. So that's quite a complex process in itself to make sure that all happens smoothly, but you will get the same vaccine for the second dose. In terms of the supply is managed nationally and depends on deliveries from the manufacturers. And then we get an allocation, a sort of fair shares allocation into West Yorkshire and into the different places within West Yorkshire based on that. We don't have forward visibility of that supply more than a few weeks in advance, and so we'll have to prioritise giving people the second dose at the right time within that supply, and then use whatever's the surplus, the remaining supply to do more first doses. We're told that supply should increase over the next few weeks, and particularly when we get into March, when we need the largest amounts of supply. So we're confident that we will be able to continue doing to deliver the second doses for people who've had the vaccine already, and continue to vaccinate large numbers of people for their first dose. But exactly how many, and whether it is a sort of doubling, as you say, we don't know at this stage. We have planned, in terms of the capacity that we put in place across West Yorkshire through the different sites, that we would be in a position to double the amount of vaccinations that we're delivering each week if we get the sufficient vaccine supply. So we're confident that we can do it. What I can't be 100% sure about at this stage is exactly how much vaccine supply we will get over the next few weeks, and particularly longer term into March. But it's increasing. Generally, it's increasing all the time. It's gone up since we started, and as more vaccines come on stream and the manufacturing capacity improves, we should continue to see more vaccine coming into the country and into West Yorkshire.
Thank you. Just on top of that, we gathered that we stretched to 12 weeks between 1 and 2. But is there a maximum period beyond which it becomes irrelevant, or does the second vaccine at any time do its job?
So I might have to defer to James as a clinician on this one, but my understanding is that what the guidance says is that you should have it by 12 weeks. So we are starting to offer people the second dose from 11 weeks, and in some cases a little bit earlier than that, to make sure that given it to everybody by 12 weeks. My understanding is that it's still better to have the second dose, even if it was a bit later, but we're absolutely aiming to make sure everybody gets it within the 12-week period. James, is there anything you want to add to that?
No, you're correct, Matthew. Matt, I suppose, yeah, there are a small cohort which will do it earlier than the 12 weeks. I think if your question was if it goes over 12 weeks, we wouldn't restart the course again. But ideally, it's between that 11th and 12th week, as Matt said there.
Thank you very much.
Thank you. Thank you. Excellent questions. Councillor Greenwood.
Thank you. The problem coming in late is everybody asks you questions, but then
there was a bit of a rush on
comments.
So I was trying to do it fairly.
Yeah, it's fine. No, don't worry. So you have to bear with me on this one. Obviously, I want to add my comments and thank everybody that's been involved in this, because it is absolutely, you know, it's absolutely amazing what people are doing. But I want to particularly give a shout out to Bradford, to be fair. We've done 145,306 vaccines, which I think is pretty good to say. The figure of 650k right across West Yorkshire, I think we're doing all right. You know, 99.8% of over 80s, 98.7, 75 to 79. So, you know, we are doing well. I also want to give a shout out to the GP surgeries, because they sometimes get a little bit of a bad press, don't they? But they've been absolutely amazing. But just on what Councillor Hutchinson was saying, it's interesting actually, because I went with my mum. She's had both of hers, thankfully, because she had hers done in the first week. She's 94, type 2 diabetic. She went and had hers. And I had to ask questions afterwards, like, how long is it before this takes effect, you know, before it gets through your system, for example? And she said 2 to 3 weeks. And there were a few questions that I had to ask that I didn't know. And I was asking out of interest for myself, really. So they're not really getting the information that they need. So maybe there ought to be a little question and answer thing done, I suppose. Because I had mine done at the BRI and I got stopped 4 times. I spoke to 4 different people before I actually had the injection. It was unbelievable. You know, it was good. I'm not complaining about it, but you know, that's the difference there. I'm going to ask about carers, but I think we've covered that with Councillor Smage. But what I was going to say about that is, because my concern is that I've had a lot of carers ringing me, really upset because they're caring for a vulnerable person. Now they know the carers, but they're not registered, so they're not going to be contacted by anybody to say you're a carer, come along and have your vaccine. So I've just been advising them to ring 119. I don't know whether that's right or not, but maybe somebody can answer that. And just one more thing as well. I do know that in Keighley, some GP surgeries now have not got the vaccine, and some people have been told that they won't have any coming in now till March. So there's a 2 or 3 week period there. I don't know, somebody might need to go away and just check that. So I just want to ask, how confident are we? Because, you know, we're singing everybody's praises for doing this, and everybody's having the first vaccine, but how confident are we that we are going to get the second vaccine in time to give everybody it within the 12-week period?
So as I said, we're confident we can get the second vaccine for everybody in the 12-week period. The doses for people to have that second vaccine have effectively been set aside from the supply that we know is coming into the country. So we're confident that that's available. We have had some weeks, so this week, for instance, is a particularly low week of supply. It's lower this week than it's been for a number of weeks, and because of that, there are some practices which aren't receiving vaccine directly this week. We are able, in certain circumstances, to move vaccine between sites if that makes sense, and we are doing some of that this week in Bradford to try and make sure that there's vaccine in the right places, where it's, because sometimes the national process for allocations doesn't quite fit with what we think is the best way, where it needs to be locally, and on those occasions we can move it from one place to another. It's quite complex from a sort of pharmaceutical perspective to make sure that we do that safely and that the vaccine's moved in a way that means that it's still safe to be used and when it gets to the new place. So it's not something we want to do all the time, but it is possible to do that if that's necessary. And as I say, we are doing that this week in Bradford to try and make sure there's vaccine in some of the places which haven't been allocated it directly this week.
Just to confirm, is it just Bradford that's not getting it, or are other places?
No, it's across the whole of West Yorkshire. There are some practices are getting it. Some practices got some last week and aren't getting some this week. Some practices got some, didn't get some last week and are getting some this week. It's because we've had to try and balance out, as I say, a relatively low supply this week. And the logistics of delivering the vaccine to so many sites and the sort of minimum amounts you have to deliver mean that you can't necessarily spread it out very thinly to every single site. So that's not ideal, and we know that the primary care sites aren't particularly happy about that, and we would much rather have much more supply and be able to give everybody as much as they wanted. Unfortunately, we're not quite in that position nationally yet in terms of the amount that's available, and therefore the sort of share that we get locally. So we have to manage some of these ups and downs, which isn't ideal, but is the reality, and everybody across the whole of the country is having to do that, not just in Bradford and not just in West Yorkshire.
Just to come back about your point about carers, the only carers that can book on 119 or the National Booking Service are people who are registered with a GP or receive carers allowance, because those are the only ones that nationally will be eligible on the system. So if they aren't, then they need to go and register with their GP. What we are doing as part of the comms work is making sure that we send all councillors, because we know how many questions you are all getting about the vaccine as well. So we'll send something to all that is clear about the process in your area. For Bradford, it is definitely that the person needs to ring their GP to register as a carer, and they may, unfortunately, just because there's been a bit of a lag in getting it out, be told they might not be eligible, but they will eventually catch up, so all the practices understand the definition they should be applying and that they do allow people to register as a carer, and then that'll put them in the system either for the GP or nationally.
Thank you. We'd really appreciate that, because we do get a lot of questions, and so we'd really appreciate that kind of tailored how to go about it in Leeds or Bradford, Wakefield, whatever. So thank you for that. Councillor Soloway, thank you for waiting, and then I'll go to Councillor Rhodes.
Thank you. I've listened to this, but I've seen it from the other side. In fact, I've just had an email this morning to say tomorrow morning, 7 o'clock, Thursday morning, 7 o'clock, I'm on car park duty at the vaccination centre. But also they've got to hit the ground running, because they've just been told today that they're doing a Saturday one, and they didn't know that at the beginning of the week. So they've had to be very reactive, and they've had to do things that they can. I mean, it's funny because people get excited about ice cream vans. Well, our vaccination centre, we get excited when the vaccine van comes, and we know that we're going to go ahead. But actually, one lot of vaccines didn't arrive until all the volunteers and the staff were in place. But that's just the way it is. It's a mammoth task, and we've got to accept the fact that it might look a bit sort of not that organised, but it is. I think I've got every faith in it, but it is a mammoth task. What I'd like to ask is, I was at one centre where there are quite a lot of people who didn't turn up for one reason or another, and maybe that was to do with people not wanting to take up the vaccine or being sceptical about it. So they vaccinated all us volunteers, and we were going out crossing the street, across the petrol station, does anybody want a spare arm, basically? And it struck me that this is how we tackle the anti-vaxxers. The more people you vaccinate of different age groups, and we only need one or two, we need one or two young people, we need a few teachers vaccinated, and they can go out and they can evangelise and say, you know what, it was summer to now. Because that's what it was with me, and that was what it was with all the other people who got vaccinated from a variety of age ranges. So we need some vaccine evangelists out there. We need to counter the anti-vaxxers, because as we go down the age group, I think we're going to get more scepticism. about it. I don't think it's unique to certain, communities or anything. I think it's as we go down the age group. I think there's going to also be a need for employers to come in on this. And I actually support an employer who says, hang on a minute, no jab, no job. This is a public duty as far as I'm concerned. And I think that the only way that we can get on top of this pandemic is to have a large take-up of the vaccine and put the trust in the science. And I think personally, I'd actually say it's your public duty, because if you want society to get back to normal, because I want it to, I think it's the way out. So that's what I'd suggest is we hit the target age groups, but we're not afraid of actually saying, hang on a minute, let's vaccinate a few young ones. Let's vaccinate quite a number of teachers who can go out into the classrooms and evangelize about it and say, it didn't affect me. It's brilliant, and that's I wonder if there's a possibility of that. I've been going out and basically saying, yes, I've been vaccinated and it's not caused me any trouble at all, and take it up. And I've actually managed to convince some people who are anti-vaxxers of the error of their ways in being able to do that. So that's my thoughts about it.
Yeah, thank you. Before I bring more specialised colleagues into, when we talked about this in Leeds, actually Sam Prince, who's the Deputy Chief Executive of the community, said, please don't do the younger age groups yet. We want to get, make sure that we've done the first 1 to 9, so because, and I do understand, but it causes a lot of problems on Facebook when a 39-year-old is done, and people don't know why, and people who are 66 are still waiting. So there is all these elements to kind of balance out, and it will be because, like you said, there's some spare ones. I'm assuming, I've got a question from what Councillor Soloway said, that if people don't turn up, I would assume it's not reluctance because they've actually had to book in. So they wouldn't have booked if they weren't reluctant, or maybe there was some travel issue or something like that. But I don't know whether anybody else wants to. But we've been told in Leeds, don't try and get your young ambassadors out just yet. Let us, make sure that we've done all the older people first. But I don't know whether Matthew, you wanted to come in on that.
Yeah, so I think I sort of understand where Councillor Soloway is coming from, but I agree with what you said, Councillor Hayden, that we have to follow the JCVI guidance at the moment. That's the best advice well, it's not advice, it's sort of guidance that we have to follow based on the risk factors for this disease. I think, as you say, the other issue is that how would you choose which teachers to become these evangelists? It would be impossible to do. So I think we have to stick to the JCVI guidance. We're expecting, I believe the JCVI have been asked to look at whether once we've vaccinated everybody over the age of 50, there are other groups within the wider population that should be prioritised, and I think we're expecting that they will come back on whether they think that's the right way to go shortly. We haven't heard anything on that yet. But what we do try and encourage all the sites to do is to ensure that they have a sort of reserve list of people who can be called in at short notice. If there are people who don't attend for their appointment, and therefore there is some I don't like calling it spare vaccine, because it's not really spare. It's just it's not being used, and we need to make sure that it's used on the day. So there are reserve lists that in that situation that we can bring people in quickly, and sometimes that will mean that there will be people who are in younger groups who get vaccinated because they just happen to be in the right place at the right time. But that's absolutely the exception, not the rule, and we're trying to stick as closely as we can to the priority groups and work our way through those as quickly as we possibly can to get to the younger people as soon as we can.
Can I just come in on the point of teachers? It's not actually license for under 18, so teachers wouldn't be, unless they're evangelising to parents, and from the kids, or get to the parents from the kids. But until it's, you know, it's not. I am incorrect in saying that it's not licensed for under 18s at the moment.
Oxford isn't. The Pfizer's 16 with the clinical discretion. We are doing work though with younger people to encourage them, exactly for that reason, though, about encouraging their family members to have the vaccine. And we're doing some stuff with local schools as well. Quite a few secondary schools covering vaccines in their PHSE lessons, and we're making sure they've got accurate information, and we're looking at links that can be made. And we also have quite a lot of COVID ambassadors in Bradford who started this, where they're younger, recognising that they will have influence on families, particularly in communities where there's more multi-generational living. So it is something, you know, to count in terms of what Councillor Soloway is suggesting, although it's not through actually vaccinating them, it is by making sure they're informed as well, and laying the ground for when it will be younger people's turn, and, you know, recognising the power of social media with the younger demographics as well. So it is something we are thinking about.
Lovely, thank you. And Councillor Rhodes, thank you so much for waiting. Oh, you need to unmute.
There we go.
Lovely.
Hello,
excellent.
Nice to see you. Yes, can I just also add, on behalf of everybody out there who's done such a magnificent job through this vaccination process, our gratitude, and to all the volunteers, etc. And when one compares how it's being dealt with at local level, as we call it, through local government, public health, and everybody else joining in, to the farcical situation of the test and trace and track, then I think they've done a magnificent job, absolutely magnificent job, and they have to be congratulated. I've listened to all the comments about it, and obviously they've been very valid and indeed supportive, and questioning about the vaccine in general, and the questions about the capacity to deal with it in terms of the volume of need. Now, there was, I believe, concerns that because Yorkshire had done so well, that the vaccine had slowed down in terms of distribution, so it could be diverted to other places. One can understand that in a way, but that view out there in terms of volume and capacity was a concern, and is that a reason why is less than anticipated? That's the first question. The second one I have is obviously connected to it as well, in terms of if that's the reason, then the allocation of the second dose, which is up to 12 weeks. And now the AstraZeneca has proven in the latest data that it is actually in efficacy right up there, which is good news for everybody, bearing in mind the bad publicity it had for a little while. And I think that's great news. So is that a reason that when we go on to the cohorts, that there may be a delay? Because if we've not got the capacity and the volume to do the second dose at the same time as we're going into the second cohort, then I think there needs to be some explanation about it. If it is we having vaccines diverted from Yorkshire to other areas that aren't doing as well. I think the comments made by Andy in terms of the cohorts as we go down, in some ways is, I think, a concern to many of the people who've already got their vaccine, because the data as well has shown that those under 50, in a particular age group under 50, are the major concern at the moment out in the community. And obviously, if in a work capacity, that would apply as well. And I appreciate that we've got to get down the age groups, but looking at the data of the age 50 and over and even under, I'm sure there's a lot of work going on in that to get that sorted out in terms of the fears of those that have had it, thinking, well, the younger people are the ones that are getting it now, so they're feeling more vulnerable. I think as well that the messages that are going out need a bit more, what shall I say, clarity in some ways. We've had so many mixed messages from national level coming out to local level to deal with. It's been a nightmare for some people, and we've all been at the end of the phone or emails trying to sort it out in our own heads, as well as give information out to our residents to reassure them. There are issues about the capacity, etc., because not far away from me, there was a pharmacy to you that actually set up in a Morrison's car park. And I understand that's no longer there. Now, when I think of what the rollout is still going to be, I have to wonder if that's down to a capacity level as well. We've spoken about the allocations, and that's ongoing, and it is a gigantic effort by everybody. Could I ask, in terms of our vulnerable communities out there, and particularly where we have multi-generational that Eleanor has referred to, do we, in terms of the information that we've got, to make it easier where we have got multi-generational and exemplified by what we can do? You may have 3 or 4 people in one house who are eligible. What about mobile units? I know in some other countries, they've actually gone to mobile units going out with the data of who in that particular community is eligible, and done a lot of work. And I know nationally there has as well, in terms of knocking on doors and putting leaflets through doors. But I'm considering and concerned about our multi-generational as well as our BME communities to say, you know, this is coming to your area sort of thing, to encourage them to actually take up the vaccine. And lastly, I think one of the queries that I've had to deal with, and I don't know if it applies to anybody else, yes, I've had the vaccine, and I'm proud to tell everybody I have, and encourage all my older people in my older groups to pass all the messages on, saying get out there and get the vaccine. I even threatened a few of them with my shillelagh, Eleanor. Now you know what that's about if you don't get out and get that vaccine. But anyway, I think that in terms of the getting the vaccine, well, there was no problems at all. All the appropriateness was there. And in fact, when I was said, oh, Betty, I said, what, have you done it already? Now, I don't love needles at all. None of us do, but it was spot on. Nothing to worry about for anybody else. And that was great. One of the questions I've had put to me in a concern is, and I'm sure Matthew and maybe James has come across this as well. When you go for the vaccination, and this is information as well, they give you a booklet, which is very good, I have to say. But at the same time, you get a little card saying what type of vaccine you've had. The AstraZeneca was on mine. And then when it goes to the second date, well, obviously you're not getting a second date because that's the way things are at the moment. But I've had people contact me who have been for their vaccination, who have not been given any card to say what they've had for when it comes around for the next one. I don't know whether this is an oversight or, as James or Matthew has said, it may be a lack of the material that the GP practices have. But one of them was not a GP practice. One of them was a hub that was opened up in a big area. So I think that is an indication to the person for what they've had for when they go back to the second one. And I think also in getting that little card, it's like a little badge of honor. I'm sorry, but it is, to say, wow, you've had this, you know, great. That wasn't happening. Information and messaging going out. I think the information going out, and I know Colin has brought this up, the information going out in some ways, and now maybe again even more identifiable because of the restrictions that are going to be lifted in so many weeks down the road. There seems to be some kind of view that you've had a magic bullet and now you're safe, instead of the understanding of the time it takes for those antibodies to be in your system, and during that time, you still have to practice all the social distancing and all the rest of it. And I think that's one message, that when people have the vaccine, that actually should be saying to the people, you still, or even on your little card, you still have to social distance and apply all the rules after you've had your vaccination. I've seen people and they've actually not had any masks on, they've had the vaccine, and they're closer than, well, I think they're closer than what they used to be before. And I think that's something in terms of information going out that should actually get more and more messaging out there about, you have to be careful, you still have to have time period, etc., for the vaccine to get into your system. But overall, I think, I mean, maybe there are niggly bits and pieces that we pick up, but even if they're a little niggly bit to us, and if somebody's had the time and effort to actually phone or email us to say, I didn't get this, it's good that we know that these little niggly pieces are out there to actually, see and say, well, why did that happen? And is there something that went wrong with it? Didn't we have the literature? If we didn't have the literature and the little cards, what's wrong with the doctor's practice who have some receptionists in there just making up some little letters, cutting off a little piece and giving them there so that they can be just handwritten to say you've been here today. But in general terms, I have to say that the niggly bits are there, but those are some of the concerns that I've had, and I'm sure I'm not on my own, but well done to everybody out there for what they've done. The volunteers, the public, our armed forces, everybody has done a tremendous job, and well done to all our local people, our local places for making it happen.
Thank you, Councillor Rhodes. I don't whether Eleanor or James or Matthew want to come in there first. James, you put your hand up. Yeah.
James, do you want to go in, and then I'll come in on some of the other bits?
I was going to say, so thank you, Councillor Rhodes. So yes, niggly but important, as you say. I think in terms of the cards, just picking up on that, it probably is a supply issue. I know at times they haven't always been coordinated, so sometimes we've been short. But I think we have made sure. I know some places have made sure where they have been short that they have at least given them something afterwards, or are planning to do that there, because I agree that having the card is really valuable, and for lots of different reasons, as you suggest there. I think the other thing about telling people not to not to kind of put down all their face masks and being close to people. Absolutely, again, it should be part of the discussion, and I think as someone who works in that environment there, as once people have had the jab, that's often what I would say. Well, I would say to them in terms of, look, you need to carry on doing all what you've been doing at this stage, at this moment there. So I think we are doing that. There's maybe something about consistency of doing that sometimes, the volume of people going through, but we are hopefully giving that message out there. That's what I was going to say, Matt.
Thank you.
Thanks. I mean, I think there were some issues right so early on in the programme, Councillor Rhodes, where because what we found is we can actually get more doses out of the vial than we expected to. We were being given the right number of little cards and things for the number we expected to get out, but then people weren't being able to get more out. So what they've now done is they've increased the numbers of the leaflets and the cards and things that come with the vaccine, so to accommodate that. So there probably are still some sort of niggly issues, as you say, that are out there, but hopefully as we pick those up, we're trying to rectify them and improve things as we go. You asked about the allocation, the sort of lower allocation at the moment, whether that was because vaccine was being moved away from Yorkshire. That's not the case. It is just at the moment we have a lower amount of supply into the country as a whole, and we are getting our fair share. It's just that there's a lower amount just for these few weeks, and then it will increase again as we go into a bit later in February and into March. So I think on that basis we're confident that there will be enough vaccine, as I said, for second doses, and to continue to vaccinate people with first doses on top of that. Exactly how the split works out will depend on exactly how much vaccine we get, and we don't know that in detail yet. You also asked about mobile units. So I think there's two parts to that. So as I said in the introduction, we are doing what we're sort of talking about as pop-up clinics in local areas. So as I said, we did some in mosques in Bradford. We've done some in similar things in Calderdale, and I know they've been doing similar things in Wakefield as well. So that would be a clinic which sets up for a couple of days in a sort of particular location to try and make it easier for a community to access the vaccine in that area. GPs are also doing home visits for people who aren't able to get into a clinic, so that we can make sure that we're not missing those people as well. So we're trying to, so probably a sort of dual approach in terms of those sort of mobile things that you talked about. And the Morrisons, the pharmacy to you in the Morrisons, as far as I'm aware, that's still operating. So I don't know where the sort of the issue of it not being there anymore is come from, but I'm not sure, it's not necessarily operating every day of the week, but it is still operating in the Morrisons in Wakefield. So Eleanor, is there anything you wanted to add on the communications side?
No, only just that I completely agree with what Councillor Rhodes said about trying to get out the information, that it isn't the magic bullet, and it is something, so we're certainly trying to include those messages in any of the media we do. And as James says, you know, that's a message that's given out the sites. I know in some of the larger ones, there's videos and information are given out. So I'm just sort of ticking over about what else we might be able to give as well to help reinforce that, because as you say, it really is very important that people understand they've still got to put their part to play in that.
Thank you so much. That's been quite a long item, but quite rightly, because it's so, you know, involved in such a mammoth effort. My mother was vaccinated at 4:30 on a Saturday afternoon by her GP, and there was 9 of them in their different nurses, GPs. That amount of effort, like Councillor Soloway put into the chat about, you know, GPs going on a weekend to villages and vaccinating 200 people. It's incredible. We're really grateful. People going above and beyond and all pulling together. So it's absolutely fantastic. So thank you. Can you pass on the board's thanks to anybody you come across who's in this vaccination process? And the community is really grateful, and we're very grateful, and a huge thanks to them all. We've got now the West Yorkshire Health and Care Partnership wider update on the response. And it will also consider an update on the partnership response to COVID-19 and other issues, including the BAME partnership support and integrated care system national policy development. So is that Ian? Are you wanting to lead on that, please?
Hi, Councillor Hayden. Yeah, thanks. I'm with that James Thomas for this item, but you've obviously received quite a detailed paper. I'll just draw out a couple of points and then open up the conversation, because I'm conscious of time. So just a couple of things to draw out then. I guess the first thing to talk about is where we are with the current sort of progression of the pandemic. You'll be aware that we've had 3 peaks in West Yorkshire and Harrogate over the last year. The first one was in April, second one November, third one January. We're at a point now where we're sort of seeing quite a steady reduction from that third peak, which was mid January. The numbers, per 100,000 population across West Yorkshire are between 100 and 200. The numbers in Harrogate and Craven are slightly lower than that, but they've dropped by over half since we were at that third peak in mid-January. The impact of that on people in hospital is obviously similar. So I think the current position is we've got 500 people in hospital across West Yorkshire with COVID. That's down from the peak in January at 900. And by comparison, the peak in November was over 1,000. So actually that November peak was the one that was had the most significant impact on NHS services. Despite that reduction, there's still quite a lot of infection out there. There's still a lot of pressure on hospitals. We've had quite a bad winter, haven't we? And what we're seeing is some of the non-COVID pressures are also coming to play in hospitals. So even though the COVID pressures are, there's quite significant pressure overall in hospitals. Fortunately as well, what we're seeing is that those death rates have fallen in line with the reduced infection too, which is what we'd expect. But still we've had over 4,000 people across West Yorkshire and Harrogate die of COVID, so really high numbers. You've heard from Matt and discussed in quite a lot of detail the vaccine programme. Obviously the hope is that as the vaccine programme rolls out, as the weather improves, as we move into spring, that keeps downward pressure on the infection rates. But I think Councillor Rhodes made a really good point that actually, there's a risk that people's behaviour will change now. I think having the vaccine might change some people's behaviour. I think the announcements yesterday, even though they're for dates in the future, that starts to change people's behaviour as well, because people think, we're getting out of this. So we're in a period where as these restrictions are eased, it's really important that people are following the rules and we're keeping an eye on the pressures. But I think generally there's cause for hope around that the worst may be behind us. One of the consequences of this past year that you'll be aware of is the ability to perform other urgent important hospital procedures has been lessened. I think hospitals done a great job in maintaining essential services, but when we've hit those peaks, one of the consequences of that is other services have had to be paused. And a big focus for us in the coming year is how we plan to bring back those services and do that in a way that's in line with our objectives around tackling inequalities and making sure that we do that in a fair and equitable way. I'll just touch briefly on the document that was published by the Department of Health and Social Care on the 11th of February, the white paper. Obviously that was published after we produced this report, but there's some quite important stuff in there for ICSs. So what that white paper does is it sets out a kind of a direction of travel for integrated care systems. A lot of that direction of travel is familiar with our way of working, strong partnerships at place level between NHS, local authorities, communities, strong provider collaborations, working in places and across system, and an inclusive and transparent approach to system leadership across the ICS, and that's kind of the way that we've been working for some years now. One of the changes is signalled in these proposals is that ICSs will be established as statutory NHS bodies. So CCGs will be abolished, their functions will be rolled up into these statutory ICSs, and the ICS will have an NHS board and a wider health and care partnership. And so we're working through what that will mean for us. And obviously there's quite a lot of work to be done between now and next April when we expect those changes to come into force. Jenny Shepherd mentioned the issue of Section 75. So one of the items in the white paper is their intention to repeal Section 75 of Health and Social Care Act. This deals with the procurement and competition rules for the NHS. We are quite supportive of that change, and NHS England ran a consultation on this particular issue a year and a half ago, and we signalled support for that. And that's because the procurement rules as they exist now are pretty bureaucratic, and they put quite a lot of burden on commissioners and providers to respond to them, particularly mental health community service providers who often have a significant proportion of their business out to tender at any one time because of the processes that CCGs have to follow. Our view is that replacing that with something that's a bit more proportionate, but continues to ensure transparency and that we deliver best value for money is a step in the right direction. So we'll need to see how that plays out in the legislation. The final thing I'll say is that one of the implications of the white paper is that staff working in CCGs and other staff, like staff working in ICS, my team, we've been told that our organisation will cease to exist in about a year's time. That's caused quite a lot of anxiety and stress for people at a time when everyone's working really hard, responding to COVID, delivering the vaccine, those sort of things. And so one of our priorities over the coming weeks is to ensure that there's a really clear transition path for those staff. We know that those staff are doing really good work, really important jobs. We know that they will continue to be needed working at place level to support the integration of services locally. So plan for that is an immediate priority. But as I've said, we'll be doing work over the next year to ensure that our ICS arrangements continue to be fit for purpose ahead of those changes coming into force in April 2022. I'll pause there because I'm conscious of the time, Councillor Hayden. I'm happy to open up to any questions.
Thank you very much. Yes, I mean, this what happens with our meetings. It does go over. There's so much to discuss. I'll start with Councillor Hutchinson, Smage, and then Clark. Councillor Hutchinson, please.
I'm also conscious of the time, and there's a lot to be said about the white paper. And I must admit, its characterisation that getting rid of the market within health services, I think, is wrong, that the market will still be there, but a lot of the transparency and safeguards that are there with the open contracting process seem to be being rolled back. So I have serious concerns about that. But I did want to focus on paragraph 29, which was about the stroke services, and asking about, stroke prevention is a major strand of this. And it's dependent on identifying risk factors such as atrial fibrillation, hypertension, and diabetes. So currently, how well is that working now that such a large proportion of consultations are taking place over the phone, where you can't actually detect these risk factors? Similarly, we know that one of the problems with our cancer results are that late diagnosis. We've focused very much on red flags, but the people that are slipping through the net are the people who don't have the red flags, where they have a combination of symptoms, worrying symptoms that maybe cancer, may not be, and that cancer is only suspected at a relatively late stage. So I'd like to know what information is available on the stage of diagnosis of the common cancers currently. Relevant, information relevant to the last 12 months when so many consultations have moved on to telephone consultations. I would also just like to ask, paragraph 37, we know that so many of the problems that we've been experiencing in the pandemic have flagged up the pre-existing problems with workforce inadequacy. In paragraph 37, it says there was a commitment to develop a system-wide workforce plan by January 2020. I fully understand that delivery of the plan will have been affected by the pandemic and the response to it. But has the plan actually been published anywhere? There was a booklet that gave a broad brush idea of workforce planning, but I haven't been aware of a published workforce plan, which was supposed to have been published by a year ago.
Thank you, Councillor Hutchinson. James, do you want to come in first on that?
Yeah.
Thank you,
Sorry.
So some really great questions, actually. So I'll just go back to your first one about stroke and prevention, and absolutely picking up people with atrial fibrillation, picking up people with blood pressure is vital. You're absolutely right to highlight the issues in terms of we've gone to more of a digital
telemedicine approach and telephone consultation. So they're opportunistic times to pick those blood pressures up, or that pulse, put your hand on their pulse and feel the pulse there, have reduced. I think there are ways around that. We're in terms of trying to, practices are using their kind of blood pressure machines and things like that to try and pick things up, that people can come in and do that at times. We're doing other things in the community as well. But it is a challenge, there's no doubt about it, and you're right to pick up on that. We've got West Yorkshire Healthy Hearts are pushing the kind of blood pressure monitoring there. We've previously done atrial fibrillation, but that was prior to COVID. So it's about trying to pick up on those opportunistic events. Patients are still coming to practices, patients are still coming to A&E, so there are times when that can be done. And I know that other times within the community, we are using these blood pressure machines, and people are doing more of the home blood pressure monitoring, and sometimes that will pick up irregular pulses and blood pressures, so people are responding that way. But it is definitely a challenge there. Your second point about cancer, in terms of picking up the red flags, there was definitely, as you'll be aware, a reduction in those 2-week referrals during the initial parts of COVID. Those levels have come back up, as far as I'm aware, in terms of pre-COVID levels of 2-week referrals. However, I still would suggest that there is a challenge there as well, because we'd probably expect more, because as you say, the numbers went down during COVID there. I think GPs and clinicians are very aware of that, and I think there's been lots of publicity about that to ensure that we are picking up on those kind of uncertainties there early and trying and making sure, so it is at the forefront of my mind about it, forefront that actually this person may have been sitting there for the last 9 months not wanting to bother us when we've been trying to encourage people to come in there. So I think we probably have a lower threshold about that on awareness when I'm talking to a patient on the phone, or maybe saying, I need to be aware that this possibly could be a red flag, and therefore either see them or do the next step in the management there. So I think those two issues there are big challenges for us. I think we are aware as clinicians about that, and so therefore hopefully taking action for that, and that may be about our threshold for seeing people or picking up on certain things. And I think in terms of the monitoring primary prevention, I think is a challenge, but I think we, again, are trying to make sure we pick up on the opportunities we have there. And I think with things like telemedicine and things like that, that can be helpful in terms of bringing blood pressure readings into the GP beforehand and things like that. But you're right to highlight those challenges. I don't know, Ian, if you want to come back on anything else at all, the other things.
Yeah, I mean, just on the workforce point, Councillor Hutchinson, you're quite right. I mean, that should have said January 2021 rather than January 2020, so apologies for that. Basically, we had to slow that work down because the folk who were leading it were spending time supporting the vaccine programme, looking at how we support the kind of the workforce challenges around the vaccine programme. So we're looking to pick that work up again. I know that Sarah Brewer, who's leading it, is keen to have a conversation with you, Councillor Hutchinson, given your previous interest in it. So we'll be picking that work up again imminently.
Thank you. I'm going to move on to Councillor Smage, but before that, we have got a working group in March all about the white paper and the ICS. So it'll only be next month, in a couple of weeks, that people will get a chance to discuss the white paper in depth. So I'll go to Councillor Smage, please.
Thank you. Yes, I think the white paper, we do need full scrutiny on the white paper. And not just once, but as it's ongoing as well. I think that's important for scrutiny really to be cited on that. And also about bringing back services and what that involves as well. I think we need some things on that. But I am conscious of time, so I'll do these really quickly, and I've reduced my number of questions. That people with learning disabilities, we know that COVID-19 has had a large impact on people with learning disabilities. And from your report, I didn't get the feel that we were doing really in-depth focus on people with disabilities, and especially with people with learning disabilities, on the impacts. And I wonder if you could reassure us that you are doing that, having that long in-depth focus and putting action planning together. Could you just confirm, please, that the mental health and wellbeing hub for health and social care services includes ambulance staff, please? And also for people who are shielding, You've got your emotional and social support for people who are shielding. Will that sort of support continue beyond shielding? Because it's not about just whilst the shielding, it's trying to get some sort of normality back afterwards as well that people may need support with. And are you supporting people who live with somebody who is shielding as well? Because it has been a long time. There will be a long shielding impact. And also I wanted to ask about your COVID-19 networking group. Does that include people with long COVID to be able to hear their experiences? And that was my questions reduced. Thank you.
So if you want, I'll come back, Councillor Hayden.
Thank you.
So in terms of the your question about kind of people with learning difficulties, there absolutely a priority, specifically in general practice in primary care. The emphasis has been on making sure that we are doing our physical health checks. I'm really emphasising that. So I know as a GP and chair in Bradford that really emphasising that with general practitioners about this and to push this up, because we know that helps. There are lots of different techniques, lots of resources to encourage people to, even if they can't or don't want to come down to the practice, that we can do it in other ways if possible there. So really, yeah, absolutely emphasis on that, and also with those with severe mental illness as well, making sure that again we're doing those physical checks there. I think we've highlighted across all of health about that, but specifically in general practice there.
The mental health and wellbeing hub, yes, available to ambulance staff. I can't answer the question about shielding and the extent to which that will continue beyond the current period, but I can get an answer to that for you. It's a helpful suggestion. And similarly on the COVID-19 group, I think having a focus on that around long COVID and the support around that, I think is a really, really good idea, and we'll feed that in too.
Thank you. Anthony, did you want to come in?
No, thanks, Councillor Hayden. I think the points have been answered. I would have been able to contribute to. So that's
okay. Lovely. Thank you. It popped up on my screen. Councillor Clark, thank you.
Yes, thank you very much, Chairman. As you know, I've been trying to get on the agenda a couple of points. They're not questions. The first one, I think, has been answered by the agenda we got today. I'm looking for the name of this organisation. The West Yorkshire Health and Care Partnership is what it's called on item 8. And I think we should now be dropping the name Harrogate from our name, because Harrogate is now in Humber Coast and Vale. And while it didn't matter all that much what's in a name, it is now causing confusion, and it's going to get dragged in because as of this morning, North Yorkshire is in a reorganisation phase, so there's sort of civil war going on. So I think we should be in the light of clarity, and indeed in the white paper it says the ICSs should reflect the geographical location they operate in. So I think it would be better if we change the name as soon as possible to West Yorkshire Health and Care Partnership. The other matter I'm concerned about is the Nightingale hospitals. I refer members to the letter, the joint letter signed by myself and Councillor Hayden on the 17th of August. It seems an awful long time. It was only 6 months ago when we asked for the Nightingale Hospital in Harrogate to be kept until 31st of March. How right we were, because at that time the pandemic had sort of calmed down. There were people, we were encouraging people to go out and sort of eat and go back to their offices. And we didn't expect the enormous upturn there has been since then. So I'm asking this committee to call for a public inquiry into the Nightingale Hospital. I don't want to start the debate now, but this committee has been in front of the curve in highlighting major issues like this. This was a tremendous success, building the Nightingale hospitals and the one in Harrogate. It was built in about 4 weeks. And this was after 10 years of bed closures in North Yorkshire and Yorkshire. And I remind members that we suffered more under the Lansley reforms than any other part of the country. That's just as it was. And I see Councillor Smage there. 10 years ago, Councillor Smage and I were 10 years almost to the month. We're fighting to keep children's heart surgery in Leeds. This has always been a campaigning committee, and I've been proud to be a member of it, although we're no longer part of the same ICS, and there are various things. But I think we need a public committee, a public inquiry into why did we never use the Nightingale hospitals. They say now it was an insurance policy, but if we had needed to use it, could we have used it? Because I wrote to the Secretary of State in 2018 saying that we were so short of staff in the Harrogate CCG at that time that it was affecting performance. So if we had needed the Nightingale Hospital, there wouldn't have been people there to man it. We would have had to take them from other places. And there were various contracts. It's just been said already in other places that, I think we need to highlight this now. It's become a bit more urgent because there will be a lot of opposition, but I think we need to get to the truth. They were a great part of our work to combat the virus, but it was never used. And this committee wrote twice a joint letter, which I was very pleased to sign with Councillor Hayden, and that was in August, saying keep it open. We then wrote again in November, before we started the vaccination. We didn't have a vaccine at that time, and we said, why don't you use the Nightingale Hospital as a vaccination centre? And we now have an excellent vaccination centre at the Great Yorkshire Showground. But why is it at the Great Yorkshire Showground and not in a Nightingale Hospital that we spent millions of pounds building? And there are so many contracts. There are straightforward questions like these, but it's how they awarded the contracts and all the other things. But I think we need to, and I understand that the Nightingale Hospital may be closing at the end of March because it will not be needed, but that is from a leak, and I'm afraid I don't understand how leaks get around. But I lived in an age when there weren't so many leaks, and it's I was involved back in 1990, well 1989, when the Present Act came in that brought in the internal market. In those days, you put out bad news on a Friday afternoon if you wanted people to not know about things. Now it seems things go out on a Saturday night by leak. But I really think we need a public inquiry, and I would like the support of this committee to call for that and to put on notice. Other people may be doing it later, but and I would just say I was involved in one other aspect, and it's nothing to do with health, but about 8 years ago, in 2014, we had the Tour de France, and I was involved in that, and many of you may have been involved in it. And it was a great day for Yorkshire. and a great day, but nobody knew what was going on. And it was years later we discovered what had happened to Welcome to Yorkshire. We need to get this done now, or put on note. But I would welcome any help you can give me to get a proper public inquiry, and it shouldn't affect the ongoing work of the pandemic.
Well, that's something for, I think, the Scrutiny Board to discuss, and I think in our meeting in March, we can maybe put that on the agenda of that working group as well, to discuss this kind of. We're not prepared at the moment for discussing it, but we discuss it next month about whether we want to take that forward. In terms of the Nightingale Hospital, does anybody have an answer into what it's being used for at the moment, and what's the time frame at the moment? Is it still the 31st of March that it will be closed down? Oh,
if I could come in on that, Chair.
Thank you, Anthony.
Yes, thanks very much. So for colleagues, I'm Anthony Keeley. I'm the NHS England Director in West Yorkshire. So the Nightingale Hospital in Harrogate is currently being used for what it has been for some time, which is for sort of diagnostic tests, scans and that kind of thing. So it's continued to be a really valuable resource for that throughout the pandemic. I think we have regarded it largely as a success that we've never had to use the Nightingale for inpatient care. It was as Councillor Clark suggested, sort of developed as a bit of an insurance policy against the NHS being overwhelmed, and the Nightingale programme was rolled out very rapidly at the point where we were looking in particular at Northern Italy and its health services being overwhelmed. And if the NHS had got to that point in April, the Nightingale would have certainly opened, but we managed to avoid that. And then in the subsequent peaks of the pandemic, we haven't got to the point where the NHS has been at risk of being overwhelmed by COVID cases, hence it hasn't had to be brought into use. It's certainly true to say that if we had needed to open it, it would have had to be on the basis of staff being brought in from our existing hospitals across the system. Of course, staff aren't sitting around waiting to be deployed in the Nightingale from doing nothing at the moment. So it would have been a case of staffing the Nightingale at the expense of other routine things going on in existing hospitals. So I think we're very pleased that we never had to do that. It's an indication the NHS was able to cope with the degree of demand that we faced. It's obviously a matter for the committee whether you want to call for further investigation.
Yeah, we can discuss that.
And in terms, sorry, just the final point, Chair, in terms of the timescale for it, there hasn't been an announcement yet about when the Nightingale in Harrogate or any of the others will be closed. So I think we need to wait for a national announcement on what the future of the current sort of contractual arrangements are for the Nightingale provision.
Thank you. I'm really conscious about time. Councillor Rhodes, did you want to come in?
Indeed. First of all, I completely understand the situation that Jim's coming from. Lots of questions, not only about the Nightingale in our area, but up and down the country and the use of them. And I think, Anthony, that you were trying to whistle in the wind there, if you'll excuse my expression. I had a discussion with our Mid Yorkshire Trust about Nightingales, etc. And how are you going to move staff from a trust in April, in the height of the pandemic, to go to the Nightingale? Robbing Peter to pay Paul is not the answer. And it was never, ever factored in as an issue in terms of how you were going to staff them. And I think that impression going out to any of the public is quite wrong. It's quite wrong. There was not the capacity to move staff last April. You had hospitals being overwhelmed in terms of the issues on COVID. And you cannot give out a statement that says you would have moved them, because at that particular time as well, the hospital trusts were actually looking at what services they could continue to provide in the longer term. And this is now where I'm coming back to Ian. Ian, one or two things, and I know time is of the essence. You've mentioned the the ICSs. I think, Chair, I've got my list here, and Liz, we've always worked together in terms of the heart surgery and everything. I think we moved off the same agenda and the same thoughts. I think it's right, we've got to have it on our agenda. I think it's right, we've got to have constant reports. I also think it's right in terms of the comment that's been made by Councillor Hutchinson of the procurement. The procurement in this pandemic has been an absolute disgrace in terms of millions and millions of money being wasted, totally wasted. And then trying to find out where some of the stock was kept that couldn't be used because they hadn't done the procurement process right. Millions and millions wasted. Now, what we've got to do is when we have it to committee, and I totally agree with Liz, and as well with the remarks that Gordon has made, I beg your pardon, Jim has made, that we have to have a procurement process that is transparent, is accountable, and is something that we can all know we're getting value for money from. Because the last amount of £70 million worth of PPE was actually procured, and when it arrived in this country, it couldn't be used because it hadn't been individually wrapped. Now imagine that is right, but the procurement of it didn't actually address that in the procurement process, that you needed to have this equipment individually wrapped, £70 million worth of money. Now that is not acceptable, and it can't be seen as an acceptable way forward because we're going under one umbrella, and this umbrella is all going to be all seen and all dancing. I think, Ian, it's important that as we go along, and you know, I do feel the nervousness of the staff and the way forward, and I do sympathise with you. I've been around the health service for a long, long time and worked in it for 20 years. And I've seen more reorganisations, I've seen more U-turns, and I've yet to see the value of it, because the value out of all of this has not got to be from a hierarchical point of view. It's got to be, what is this going to produce for the patient? The patient. And let's have a look at that. And I totally agree that this is something we got to stay on. And lastly, before we go, Chair, we think we know we have members of the public that tune into our, I hope, and into our system here of platforms of meetings. Could I just ask, I'm always wary of people listening in who may not have the benefit of minutes in front of them. And we do, and we're all guilty of it. We all use abbreviations. And for somebody out there who's wanted to listen on how our committee, or my committee in Wakefield, or any other committee, could we have a glossary of terms of somehow of the abbreviations? You know, ICS don't mean a thing to some people if they can get onto the system. And we have all these CQCs and all the rest of it. And is it worthwhile on the minutes for people that can get onto the system to actually have the glossary of terms so they can understand what this is, as well as being able to listen in? I'm always conscious of that. If that's something that's a consideration, I think it's worth looking at, Chair.
Thank you. And yes, that's something that's been called for in Leeds as well, at a place level as well, because it can get very confusing for lay people with different abbreviations. Just to, before Ian comes back, but yes, that's the reason why we set up the working group in March, to have a really good look, and it will continue obviously over the next few months and year to look, and this committee really wants to have a good look at the white paper and all the changes that have been brought in and whatever, and that's why we set up the working group in March. Ian, do you want to come?
Yeah, happy to. I mean, welcome that in terms of the role around the white paper, and looking forward to kicking that conversation off. Obviously, it's a significant undertaking for us. We want to get it right. On procurement, I completely agree. I think the three words you use, transparent, accountable, and value for money, that's exactly what we want from a procurement process. I think, you know, I think the point about Section 75 is that sometimes it's been over the top in terms of the volumes of stuff that's had to go through that process, and that's what we're looking to have a bit more proportionality about. The points around reorganisations, yeah, I mean, I've been part of 5 of them. And they do cause anxiety. They do distract from the the job in hand. And I guess what we're trying to do is provide as clear a path for staff as soon as possible so that we minimise that stuff. But I think the wider point's well made, that there's a deadweight cost of reform that never seems to get factored into these conversations.
Thank you. And this discussion will go on about procurement, about the Nightingale Hospital, about and we'll discuss as a board. And these sorts of looking back at the pandemic and assessing what went right, what went wrong, what do we need to learn from it. I think it's going to be an ongoing process. But one, unfortunately, I'm not going to be part of, because I can see Councillor Latty Graham smiling. It's really exciting, but I've been asked to be exec board member on the Leeds Cabinet for, let me get this right, climate change, transportation and sustainable development. So I would taking everything I've learned from the 4 amazing years, or nearly 4 years, very nearly 4 years, of health scrutiny into the planning world and the transport world, and see if we can get health really embedded in that. So the reason I wanted to say is to thank everybody on this board, all Ian and everybody, all the health colleagues that I've come into contact with over the last 3 or 4 years. It's been an amazing experience, and one that will be passed on to somebody else in terms of the lead scrutiny. We had the election last night, but can I, before we go into the work programme, so I just wanted to say that, and NHS colleagues, if you wanted to leave, then,
and thanks, Councillor Hayden. And just to say, we've really appreciated the role that you've played and the way that you've worked with us to help get these arrangements right over the last 3 or 4 years. So
thank you very much. Yes,
we will depart at this point, if that's
okay. Yeah, I'll just have to go and tackle climate change now. But I'm stepping into big shoes where the Council of Heron's left me. But yeah, it's thank you very much. And thank you for this afternoon. It's been a long one, but really informative and really, really, kind of like inspiring as well. But it's a conversation that will continue. So take care.
Thank you. Thanks. Bye. Bye.
Thank you. Bye-bye. Thank you. So in terms of the work programme, before I bring in Mike on that, can I suggest to the board, or can I propose that Councillor Greenwood would take over just in the interim till the next meeting's the 22nd of June, the official meeting. We've got the working group in March on the white paper and everything going to do with the ICS and things like that, and then might need somebody to kind of like go to with anything that might crop up that the board needs to about. So can I propose that Councillor Greenwood take over from me in that role until the 22nd of June, and when we've had the local elections and we're a bit more noticed. Will that be in agreement with the board? Yeah, I'm seeing nods and I'm not seeing anybody. So thank you, Vanda, for stepping up there. I really appreciate that. And that'd be great. I might have to come and listen in because I'm on with my fingertips, especially my children's stuff as well. I was like, don't want to lose it. Okay, Mike, would you want to talk about the work programme going forward?
Just very briefly, Chair, thank you. So we have talked about, we haven't planned exactly, but to have an informal meeting, what has been referred to as a working group, an informal meeting to look at the white paper and the ICS. Having listened to the discussions today, I think that if we're going to include in that discussion the Nightingale Hospital issue, as I think you suggested we should do, we may have to
take the opportunity of us being together, and
I think we need to we'll need to have a little think about whether at least part of that meeting should be a formal meeting, because if you do want to make some recommendations like Councillor Clark has proposed, we may need to.
I was more thinking about having a discussion about whether we ask for a public inquiry, and that part of, would that have to be done formally?
I think we'd. I'd have to have a think, Chair, but I think we'd need to do that as a formal decision of the board, rather than, in other words, on a public agenda. So, but we could probably do a two-stage thing and have a seminar about the ICS, as you've suggested previously, as a board, and then have a formal thing on the same date. And I can see Councillor Smaid just sort of. Yeah,
that's what I was thinking. Yes, if we have the discussion. Yeah.
So the only other thing that I will get on with checking out a date in the second half of March for you to have both those parts of the meeting, and we have fixed or proposed fixing the what was going to be the next formal meeting of the board for the 22nd of June. Which will be the first formal meeting, as Councillor Hayden has said, of the board after local elections and the annual meetings of council. I just wondered if I could take the opportunity just to refer back to the discussion right at the beginning of the meeting about the minutes, and I just need to check that Kirsty, who's working with us today, has picked up the work of the previous minute taker from the last meeting, Carol, who doesn't work for Calderdale Council anymore. So Kirsty has had to pick up getting the minutes into some form for this meeting at short notice. But we'll have a look at them again, and we'll take on board the comments that people have made. So thank you, Chair.
Thank you. Councillor Clark.
Yes, it was just a quick point on. I know it will be in the minutes, but I think I'd like to highlight the fact that we have put on notice that we are going to, or concerned about what's happening at the Nightingale, because I think this might become a big issue throughout the country, and once again it's this committee that is leading debate on this, and therefore if we can say that this committee considered to take forward the possibility of a public inquiry into the running of these hospitals, because as Councillor Rhodes said, it was never going to work. There were no staff. I have a letter I wrote back in 2018 talking about this, and there was a letter written to say that Harrogate were acting unlawfully at that time. But
remember,
you remember that, and can I just congratulate you on your
thank you.
And I'm not sure what's going to happen in the future, but I will be at the meeting in March, but I think this might be coming to the end of my time involved with this committee that goes off over many years, and it's been a great pleasure, and to have been involved with the tremendous victory we had in relation to Yorkshire. You should always take enormous credit for what Yorkshire did in keeping the services at Leeds. And Councillor Smaid and Councillor Rhodes, remember, I was in a minority of one when we started, because being from North Yorkshire, I wanted both Leeds and Newcastle to be. And I always remember the turning point at one meeting in Leeds when it was Councillor Rhodes I'd been banging on about how we needed both hospitals to be kept, and we needed they had to stay open. And Councillor Rhodes was going to speak after me, and I remember thinking, and I've said this in public, I thought, oh my God, when Councillor Rhodes, because she was a formidable opponent at that time, and she made the words, I think there may be something in what Councillor Clark's saying. And from then on we worked, and that was a tremendous effort, and it was people from North Yorkshire, children from North Yorkshire, and as well as Leeds, who would have suffered and would have died if we had not got that victory. And I think the people of Leeds and West Yorkshire should be very proud of the work they did, and also the work they're doing. I mean, so I've been involved with the health service for nearly 40 years, and it's a fight, and we have to keep fighting for it.
We do.
But anyway, I wish you well as
thank you, and thank you for your long service and for always fighting. You know, because that's what we need to do. And it was a great victory, and it was my colleague Councillor John Illingworth with his forensic brain that went through everything, wasn't it?
Well, it was Councillor Mulheron. I don't know if she's still around, but
she is. Well, I'm taking over her job.
And when we had to give evidence to the IRP, which we had to give twice, and that's no easy matter. And I remember all the statistics. She's brilliant. I had to present on transport, because it was people who were coming from Craven and other parts of North Yorkshire were mainly interested in the transport, and I know Councillor Smage and others were involved in the fact that there were so many people from of Asian origin who had difficult genetic interests, and it was tremendous. It was done.
Councillor Mulheron is she's going. I'm taking over on the exec board from her in her role, and she's going to be chief executive of the Marketplace, which is a wonderful charity in Leeds that helps children and young people with mental health issues. So she's and she was exec board member for health and things like that. So, and we went to the same school. She was a little bit older than me.
Well, you can pass on my best regards to her.
I will. I will.
A very good chairman.
Well, I see her on Zoom quite a bit, but not personally now, not since her birthday. But I will. And thank you for your long and all the best with what you're going to do in the future, and maybe have a rest. I don't know.
Well, I've got a major issue on climate change at the moment, so we might meet again.
Okay. Anybody else want to? Mike, did you want to come in?
No.
Betty. Betty, Councillor Rhodes.
I'm here. Congratulations, Helen.
Thank you.
And for all the hard work that you've done. It's been a pleasure as chair. And please pass on my regards to Lisa, because I think we trained her well when she was in Wakefield, and I'm so proud of her. She's lovely. And
she is.
As well. I'm sorry we've been losing you on this committee. We did, and you know, it was worth it, because we weren't doing it for ourselves, none of us. We were doing it for the people that need service in Yorkshire. And whatever you go on to do, Jim, well done. And of course, both of you, in terms of climate change, we'll still have to consider from a health point of view.
Absolutely.
What's happening. So we'll keep our eye on both of you over there. Now, I just wanted to say one thing in terms of this, what Mike has put forward for this seminar, and the proposition that Jim has put forward, Councillor Clark, about a public inquiry. What I would suggest from today's meeting is that legal advice is sought in terms of the terms of reference that we have as an organisation, as a joint committee, to engage in this venture, and what that would entail. Now, I don't know whether that would be something which all the leaders of our various authorities might have to be made aware of. And as well as that, when one looks at how public inquiries are held, it's not an instant procedure, as we all know. And of course, on top of that, there's always a cost implication for a public inquiry. So I think that if I could suggest that from today's meeting, it goes forward on an exploratory role as to what the process would be for our committee to engage in that. But in the meantime, I think obviously it's worth noting from Councillor Clark, from Jim's point of view, that today a discussion took place, as he quite rightly said, about the various issues, and that the committee are under consideration of how to engage on a wider platform about this subject with the public at large. And I think if you say the public at large, it just actually indicates that it's possibly going wider, but we need that clarification legally.
Yes, you're quite right. Yes. Okay, so Banda, Councillor Greenwood.
Thanks, Helen. Yeah, I just want to add my congratulations. You've got one heck of a portfolio there, girl. It's going to keep you busy. And thanks for all you've done. You've been a really, really good chair and really fair.
Oh, thank you.
Let's hope I can do it justice for the next meeting. And my son is a maths teacher at Lawnswood, if you need any help.
Funnily enough, I've got a sister and a brother who are both maths teachers.
Oh, well, there you are then.
Ironically, yeah.
Yeah.
It's a great school, is Lawnswood, yeah.
Yeah,
it's great. Okay. Mike, did you want to say something?
No.
No, right. Well, thank you all. Thank you. I'm really, really going to miss getting together with you all. I mean, the amount of intelligence and, you know, kind of sheer hard work that goes into these meetings from all the board, you know, and big thanks to Mike and all the, you know, Stephen, but everybody behind the scenes who supports, you know, the officers, who supports this meeting, because it's never a simple one, is it? It's never, there's an awful lot in every meeting. So taking the minutes and everything else, I mean, it's a mammoth job to do with these sorts of meetings, but really worthwhile. And like Jim talked about, and the you know, this committee, I mean, not me, but this committee has had some really big, you know, wins, especially with the Children's Heart Hospital. But also, like you said, we're at the forefront of seeing, you know, Colin's suggestion, you know, it's kind of like in the summer, writing to the government about support for people who have to isolate and things like that. So we are at the forefront, and you will continue that.